So Dr. Sultani, again, welcome to the meeting. Now we have officially started our webinar, and from your list of participants, you can see our attendees are very quickly streaming in. And so I would want to hand over this meeting to you. Thank you.
Thank you very much, and welcome everyone who has already joined us. You're welcome to this second conference of the LEAP. My name is Dr. Sultani Matendechero. I'm the chair of the LEAP Advisory Committee. And I want to start by apologizing for not being able to come and join the participants who are attending physically. And just to say that, you know, something has come up at the office, but then we will still be able to go on, even as I attend to this very abrupt issue that has come up. Now, I hope that I'll be able to come and join in as we proceed, because this is an event that is extremely important to us. So we are going to give the participants, I don't know how many we have. I think we can start at this particular point in time. And so I will want to just introduce Dr. Monique Wasuna, who is the African Director of DNDi. Dr. Wasuna has taken a leading role in you know, working with the DNDi and establishing the LEAP platform, which has also been very instrumental in, you know, coming up with the new products that are very useful in terms of, you know, pushing the agenda for control and the elimination of leishmaniasis forward. Now, at this juncture, I just want to bring in Dr. Wasuna, so that she can welcome the guests, and then we can proceed from there. Welcome, Dr. Wasuna, just for an opening word.
Thank you very much, Dr. Matendechero. The chief guest, the Acting Director for Health and Humanitarian Affairs, AU, Dr. Margaret Anyete Agama, represented here today by Dr. Sheila Musonda, Executive Director of DNDi, Dr. Bernard Bekul, Acting Country Representative, World Health Organization Kenya, Dr. Juliet Nabionga Orem, Director General, Medicines Sans Frontiers, MSF, Eastern Africa, Dr. Ronald Kaya, Acting Director General, Kenya Medical Research Institute, Professor Samuel Kariuki, Director, Institute of Endemic Diseases, University of Nairobi, Professor Montasa Ibrahim, distinguished participants, ladies and gentlemen, all protocols observed. On behalf of LEAP and the DNDi, I'm pleased to welcome all of you to the second LEAP scientific conference. It's themed Scientific Innovation and Access for Leishmaniasis Management that is taking place from today until the 4th of November. As you might all well know, LEAP was founded in 2003 in Khartoum, Sudan, with 16 members of this platform from over 20 institutions. The LEAP platform is a clinical research network that brings together experts from leishmaniasis endemic Eastern African countries of Ethiopia, Kenya, Uganda, and Sudan to facilitate clinical testing and improved access to better treatments for leishmaniasis in the region. In 2014, LEAP was then very young and then, but very confident and desired to engage scientifically with its members and partners to address the issue of how to bridge the research and innovation gap for visceral leishmaniasis, which I'll, you know, abbreviate as VL in this address in Africa. This resulted in the first LEAP scientific conference, which was held on the 29th to 30th of September 2014 in Bahir Dar, Ethiopia. I'm excited today because we are gathered as scientists, researchers, policymakers, public health practitioners, civil society, the media, and the community at large to discuss the advances and the gaps in the diagnosis, treatment, control, prevention, and elimination of leishmaniasis. what various groups are doing, and really to share information. This second LEAP scientific conference was planned to be a forum to also present results from the Africadia Consortium projects funded by the European and Developing Countries Clinical Trials Partnership, EDCTP. This project is part of the EDCTP2 program, which is supported by the European Union under Horizon 2020. Africadia is really a consortium of 10 organizations working to find improved treatments and diagnostic tools for VL in Eastern Africa. These organizations include 3 universities and 1 research institution from Eastern Africa, 4 European research institutions, and 2 not-for-profit product development partnerships specializing in research and development for neglected diseases. The scientific organizing committee for this conference is comprising of eminent professors, scientists, researchers from local, regional, and global institutions, and they have put together an exciting agenda for us for the next 3 days. The scientific agenda is really rich with 21 abstracts, 11 posters, and the conference will cover all forms of leishmaniasis, including VL and HIV co-infection. There'll be 2 keynote addresses, one which we'll receive this morning, and the other is by Africa CDC, which will be a closing remark and a presentation on the effects of COVID-19 in Africa. Where are we in this current pandemic? What are the lessons learned? What we do need to do for the future? So this will be very exciting, and it's at the end, so please don't miss it. There's also a training planned during this conference to equip the participants with key tools that are required to raise funding for projects and for organizations in Africa. This is free, please also don't miss it. We have a very exciting program. So really thanks to the scientific committee, and we also want to thank them and the conference organizing committee, and we'll do this at the end of the conference. There are over 420 participants who have registered for this conference from over 20 countries, and 10 of them are from Africa. I could name a few like Ethiopia, Uganda, Sudan, Kenya, South Sudan, DRC, Ghana, Morocco, Tunisia, and so on. And then we have also the rest of the world joining us: India, Switzerland, United States of America, UK, Netherlands, Belgium, France, Canada, Brazil, and Colombia. So this is really exciting, and we have literally everyone from every part of the world attending. COVID-19 has taught us to enjoy every moment. So I ask you to indulge and enjoy the second LEAP scientific conference. Let us discuss together and contribute to the plight of neglected patients that are looking up to us to solve the issue of leishmaniasis. We are looking forward to fruitful interactions. Please feel free to engage with us throughout in our social media platforms, and also through the Q&A system. Once again, a very warm welcome to our chief guests, the dignitaries invited, the presenters, the colleagues, and all participants. I really want to thank you, and thank you on behalf of DNDi, LEAP, and the organizers. Have a very enjoyable experience. I'd like to thank you very much. So thank you, Dr. Matendechero, over to you.
Okay, thank you very much, Dr. Wasuna. At this juncture, I would like to invite our keynote speaker, who is Professor Muntasa Ibrahim, herein represented by Sheila Musonda. But I will just read out to you Professor Ibrahim's bio. He is the director of the Institute of Endemic Diseases at the University of Khartoum, Sudan. He's a professor.
Dr. Matendechero.
Yes.
Oh, you are presenting. Monique. Yeah. Ibrahim is not represented by anyone, you see?
He's with us here today.
Yeah, Ibrahim is supposed to be here. But if he's not here, he had sent an apology because he's from Sudan, and you know the problems that we have in Sudan. So he may or may not attend. So if he has not connected, then he's not there.
Okay.
Yeah.
All right. So at this juncture, thank you very much, Dr. Monique, for that clarification. I will now call upon Sheila Musonda to make, on behalf of the keynote speaker, to actually give us the remarks. So welcome, Sheila, over to you.
Good afternoon. Thank you so much for this opportunity. So senior government officials, representative of various organizations, distinguished ladies and gentlemen, all protocols observed. On behalf of Dr. Margaret Agama Anyetai, Acting Director of Health and Humanitarian Affairs, and the African Union Commission, allow me to express our sincere gratitude for inviting us to give the keynote address at this very important event. The second LEAP Scientific Conference is a significant event because it highlights the critical need to eliminate leishmaniasis as a public health problem. This path aimed at controlling and eliminating NTDs in Africa consists of great milestone. Recent data published by WHO confirms that in 2018, more than 1 billion people were treated for at least one of the 5 NTDs targeted for control and elimination. It brings me joy to note that in the recent years, a number of countries have eliminated at least 1 NTDs on the continent. Although leishmaniasis is not among the diseases that have been eliminated, this conveys a lot of hope that we are on the right track. A study undertaken by the Commission in 2020 showed that 14 out of 40 countries that responded to the survey reported the occurrence of leishmaniasis. I'm sorry, I don't know why I'm blabbing on the word. Out of all these, 4, namely Ethiopia, Kenya, South Sudan, and Uganda, are found in East Africa. This underscores the importance and timely manner of this conference. Distinguished ladies and gentlemen, the African Union notes the challenges faced by member states in responding to NTDs, including leash. To this effect, the Commission, in collaboration with member states, developed the Continental Framework to control and eliminate NTDs by the year 2030. The framework is a strategic document designed to provide guidance to the AU member states in response to the fight against NTDs on the continent. This is in line with the aspiration of the Agenda 2063, the Africa we want. The Agenda 2063 has brought about the revitalization of frameworks to ensure that objectives of the healthy and well-nourished citizen is attained. Further, the Commission developed the Africa Health Strategy, an overarching document that provides strategic guidance for member states in the implementation of priority approaches to reduce morbidity and end preventable mortality from all diseases, including leishmaniasis. Esteemed ladies and gentlemen, leishmaniasis is a vector-borne disease, and among the strategic approaches being advocated for in the Continental Framework is the need to utilize alternative strategies in response towards NTDs. Elimination of leishmaniasis as a public health problem will only be attained if strategies such as vector control, health education, improved disease diagnosis and management are intensified. Focus on prevention will lead to a decrease in transmission and hence the need for intervention plans on all aspects of control and not standalone interventions. There is need for intensive advocacy at political, regional, and national level for the provision of sustainable financing towards development of new technologies in treatment and diagnosis of leishmaniasis. The African Union and stakeholders are advocating for increased funding towards research and development in this sector. The Commission is also urging member states to create an enabling environment for research and development, among others. Ladies and gentlemen, as I conclude, the African Union Commission is committed to the attainment of the aspiration 1, goal number 3 of the Agenda 2063 of a well-nourished and healthy citizens. Therefore, we will continue to support member states and partners to ensure that leishmaniasis is eliminated as a public health problem on the continent. We will also work with partners to ensure that success is realized to the end. Once more, I thank you for making time to be part of this important conference. I look forward to fruitful discussions. Thank you very much.
Thank you very much, Sheila Musonda, representing the keynote speaker. At this juncture, I'd like to apologize for getting it the other way around. Actually, Sheila was supposed to come in after the other speakers. Nonetheless, we will revert to the required schedule. And at this point, I'd like to invite Professor Muntasa Ibrahim, who is a professor at the Department of Molecular Biology at the Institute of Endemic Diseases, University of Khartoum. Professor Ibrahim obtained a BSc in zoology and chemistry and a PhD in molecular biology. He was a Wellcome Trust visiting research fellow, Department of Pathology at the University of Cambridge. He is a founding member, Sudanese National Academy of Sciences and African Society of Human Genetics. Professor Ibrahim is a fellow of the Academy of Science for the Developing World, Arab Regional Office, and African Academy of Sciences, AAS. His research interest is primarily on the evolutionary aspects of diseases in relation to human genetic diversity, with particular interest on ethnicity, including the role of disease in ethnogeography. In 1998, he established the Unit of Diseases and Diversity, which has its focus on the study of human and parasite genetic variation. The unit contributes to the institutional efforts in research and training, including training courses on molecular medicine, bioinformatics, and genetic epidemiology. He was recently awarded the C.N. Rao Prize for Scientific Research by the World Academy of Sciences, that is TWAS. Ladies and gentlemen, join me in inviting Professor Muntasa for his presentation. Over to you, Professor. Professor, if you can hear me, please go ahead.
Sorry, can you hear?
Yes, I can hear you now. Please go ahead.
This is Simon Bolo. Just informing you that Professor did not join in, probably due to the situation in Sudan. So we could move to the next speaker, please. You're muted. Sultani,
You're muted, Sultani. You're muted.
Yeah. Okay, thank you very much, Dr. Monique. In that case, then, ladies and gentlemen, we will move on to the next speaker. Our next speaker is Dr. Samuel Kariuki. Professor Samuel Kariuki, beg your pardon. Professor Samuel Kariuki is the Acting Director General at the Kenya Medical Research Institute, that is KEMRI. He is a fellow of the African Academy of Sciences and an honorary faculty at Wellcome Senja Institute. He is a visiting professor of tropical microbiology, Nuffield Department of Medicine, University of Oxford in the UK, and a member of the American Society of Microbiology. He won the prestigious Pfizer Prize, that is the Royal Society for African Scientist of the Year Award in 2012. He holds a PhD in tropical medicine from the University of Liverpool. I would like to invite you, to ask you to help me welcome Professor Kariuki so that he can make his presentation. Over to you, Professor.
Thank you very much, Dr. Sultani. Dear delegates, all protocols observed, very, very grateful and very pleased to be participating in this second LEAP conference. This is really, to us at KEMRI, a very momentous time. We just celebrated, as you know, the launch of the strategic plan barely a couple of weeks ago, again spelling out the DNDi strategy in addressing especially the area of neglected tropical diseases that continually affect our region very disproportionate, in a very disproportionate manner, and especially among the most vulnerable, the very poor and those in marginalized areas. So I see this second LEAP conference, though of course addressing mainly the area of leishmaniasis, but also going to provide novel technologies and the new ways of looking at how we can better understand how diseases in general, but specifically leishmaniasis, can be detected much more quickly, much more professionally, and much more efficiently to be able to provide management options for patients that are involved. I take particular great pleasure to recognize the efforts of my colleague, Professor Wasuna. Monique, really a relentless lady that has, won this battle almost. Because looking back at how she started this organization for the region, I can tell you that this has been a great achievement for DNDi, for Kenya, and also for the region. And I take pride in noting that there have been a lot of advancements in areas specifically on diagnostics, but also on access for treatment and management options for various NTDs. I also wish to thank particularly those that we work with in terms of collaborations for providing to us ways and means of getting together minds that will be able to tackle these NTDs in our region, particularly looking at how best we can be able to improve livelihoods and lives, especially because most of the NTDs are poverty related. How can we best then address the issue of social inclusivity with how we deal with diseases such as NTDs by giving the best technologies to be able to approach diagnosis, to be able to approach management in a manner that will provide very immediate relief to those that suffer from NTDs. I'm therefore very grateful that this second LEAP conference is going to look at various thematic areas, not limited to just the area of epidemiology, the area of clinical care, but also the areas which we could improve in terms of technologies for purposes of discovering new molecules and new ways of dealing with NTDs. And therefore, my great pleasure to wish all of us a great second LEAP conference. God bless you all as we participate. Thank you.
Thank you, Professor Kariuki, for that very informative presentation. I would like to just inform you that, probably before I do that, I'm happy that Sheila is still online. As I apologize again, Sheila, for bringing you much earlier than your time. I will go further and request you for a special favor so that we will call you back again, just to make sure that we observe protocol. We will have 3 more speakers, and after those speakers, then we will have you just come back so that you can be able to take us through the keynote address again. I'm very sorry for that. Now, our next speaker is Roland Kerr. And Roland Kerr is the General Director at MSF Eastern Africa. That is Medicine Sans Frontier. Roland is currently General Director for MSF Eastern Africa. Originally from Congo, Brazzaville, is one of the very dedicated and committed MSF staff who joined the organization in 2002 as a national staff in Congo, Brazzaville. Since then, he remained attached to the organization and filled different positions within MSF at national and international levels as project coordinator, deputy head of mission in various contexts, that is in Congo, Brazzaville, as well as DRC, Chad, Pakistan, Somalia, Uganda, South Sudan, and Ethiopia. And recently worked as the MSF humanitarian representative to East and Central Africa, based in Nairobi, Kenya. Roland holds a master's degree in public health, environment, and health promotion, specialized in developing countries. And without any further ado, I'd like to hand it over to Roland Kerr. Over to you.
Thank you very much for inviting me. Dear guests, dear colleagues, I'm very pleased and honored to be part of this panel today. As you know, Doctors Without Borders, Médecins Sans Frontières, is one of the pioneers in terms of responding to emergencies and also taking part in addressing issues and gaps related to neglected diseases. For the 50 past years, we have been in the field of action. We have gone through different operations and have identified a lot of gaps and medical challenges which we have faced at several occasions. And one of the biggest gaps have been the neglected disease in different places, in different countries, and on different continents. The neglected diseases has been an area where we have felt that Doctors Without Borders could do more and invest a bit more in terms of advocacy, in terms of actions and field operations. That is why when the organization was awarded the Nobel Peace Prize in 1999, we have felt that part of this award should go into this area. And that is why a portion has been invested in creating an opportunity to fill the gap in terms of neglected diseases. Since then, the organization has committed itself to work in different areas, mainly operational research, with different actors and partners working alongside in the field, Ethiopia being part of them, to help, assist, and also bring some key and practical solutions which could help gapping the issues we have been seeing in the field. As part of this commitment, all or most of operational entities of Doctors Without Borders have put in the strategic plans, the responses to neglected diseases and other pathologies as part of key areas where we need to invest. And leishmaniasis has been one of the areas where the organization has been investing a lot, treating thousands of patients, mainly in Eastern Africa and also in Asia. So in this regard, our organization will continue standing together with different actors to continue the fight against neglected diseases. And we are also committed to continue advocating, investing, whatever is possible to support any organization or any entities who are willing to take this challenge. On that, I would say thank you again for inviting us, and hope that this conference will help bridging more gaps, and also help people around the world to find solutions to the issues, to the diseases which are causing thousands of deaths which could have been avoidable if we put all our hands together. Thank you very much.
Thank you very much, Roland, for that very precise and informative presentation. Dr. Bernard Pikul, I can see your hand is up. Did you want to say something, or yes, please go ahead. Oh, okay, sorry. I just saw that you had raised your hand. Now, our next speaker is Dr. Juliet Nabionga Orem, who is with us here. Dr. Juliet Nabionga Orem is the acting WHO country representative in Kenya. She is in charge of health policies, strategies, and governance. She also heads the health systems and services cluster of the WHO Inter-Country Support Team for East and Southern Africa. Previously, she was the regional advisor on health systems partnerships, monitoring and evaluation based at the WHO Regional Office for Africa in Congo, Brazzaville. Dr. Nabionga Orem is a graduate of Makerere University in Kampala, Uganda, where she obtained her MBCHB, obtained an MSc in Health in Economics from the University of New York, the University of York in the UK, and a PhD in Public Health from Catholic University in Louvain, Belgium. Her core experience in health systems development spans over 16 years within Africa, focusing mainly on building countries' capacity in policy development, health financing, designing, implementing, and evaluating health sector reforms and health systems performance assessment. At this point, I would like to turn it over to you, Dr. Juliet Nabionga Orem.
Thank you so much, Dr. Mutendechero, and thank you so much, the organizers, for inviting WHO and inviting me. Ministries, ministry officials here, the partners, the researchers, all protocol observed. I'm so pleased to be speaking on this, the opening of this second scientific conference of the Leishmaniasis East African Platform on behalf of the World Health Organization. Indeed, scientific innovation and access to leishmaniasis management, which is the theme of this meeting, is timely, especially as the East Africa sub-region needs to accelerate progress towards the attainment of SDG 3, which includes ending leishmaniasis and other neglected tropical diseases by 2030. As you are all aware, the East African sub-region bears a significant burden from leishmaniasis, which is an ancient and complex disease, especially among the vulnerable and the poor of our communities. And indeed, the representative of the AU spoke earlier alluded to this fact. And also Professor Kariuki also alluded to this issue of disproportionate burden. And perhaps we are aware of the statistics that in 2020, 57% of visceral leishmaniasis cases reported globally were from East Africa. And again, globally, the WHO African region contributes 14% of the disease burden, with over 12 million infected cases and 2 million new cases annually. And 13 countries of the WHO African region are endemic to the disease. As you do know, leishmaniasis is a complex disease that manifests differently in various geographies, and thus the responses needed to be adapted to the local context, which brings an added layer of complexity. And as we talk of leaving no one behind, we are concerned about the poor segments of the population. Like other neglected tropical diseases, leishmaniasis affects some of the poorest people and is associated with malnutrition, weak immune system, poor housing, stigma, discrimination, among others. And this reinforces the cycle of neglect and poverty. These grim statistics and challenges notwithstanding, again, we do note that we've made some progress in the elimination of leishmaniasis. And also we look at some milestones. Some of these are WHO action points, but also other major achievements along the path. It's noteworthy that visceral leishmaniasis cases have decreased significantly from over 64,000 in 2011 to slightly over 12,000 in 2020. And this is according to the WHO recent reports. In the East Africa sub-region, the East African sub-region has contributed to this progress. And I'm pleased to highlight a few other key milestones that WHO, working with many of our partners, including you, the scientists, and other policymakers who are attending this conference, have contributed to. And I'll just mention a few. We take note of the 68th World Health Assembly resolution in 2007. And this mobilized political support and consensus towards the vision of a world free of leishmaniasis. And by this resolution, WHO member states, where leishmaniasis was a significant public health problem, agreed to reinforce efforts to establish national leishmaniasis control programs and the systems for surveillance, data collection and analysis, and making use of this evidence to improve their own programs. We also take note of the Global NTD Roadmap 2021 to 2030, and this was launched, and it explicitly targeted visceral leishmaniasis for elimination as a public health problem. And this built on the rich experiences and lessons many of the partners attending this meeting shared. And by endorsing this roadmap, endemic countries, including East African countries, agreed to take action and accelerate progress towards a world free of leishmaniasis. And some of the actions committed to include programmatic shift and strategic approaches. And this makes reference to change in operating models, increasing country ownership, and implementing cross-cutting approaches. Also takes note of operationalizing key strategic pillars, including ensuring universal access to NTD diagnostics, interventions, treatments, and enhancing technical foundations to tackle NTDs. Now, turning to Kenya, and as the World Health Organization, we've supported the development of the National Leishmaniasis Control Strategy 2021 to 2025, which was launched in June 2021. And it's a vital milestone for the control of the disease in Kenya. And this strategy provides a platform for all key stakeholders to join efforts in speeding up results and also ensuring impact. And again, we've supported several processes in Kenya as the World Health Organization. Among these is our support to the Ministry of Health, to county governments and partners towards leishmaniasis control and elimination. Capacity building, which includes training of health workers on appropriate prevention, diagnostics, case management, and logistical support. Strengthening program management at the national and county level, strengthening surveillance and reporting, also strengthening district health information systems, and to make sure that the monitoring of neglected tropical diseases, coverage of interventions, and also reduction in prevalence is reported as part of routine information systems. In 2017, when Kenya experienced an outbreak of visceral leishmaniasis in Marsabit County, WHO and partners supported the Ministry of Health to coordinate a multi-agency emergency response to the outbreak. And again, as WHO will continue to provide technical support and increase capacity of the NTD program to enhance preparedness response, and also build resilience. Now, ladies and gentlemen, I want to talk about significant scientific innovations that are needed to fill the gaps and improve access to management of leishmaniasis in East Africa. Despite the progress made, scientific innovations are needed, and I will highlight a few. The poor understanding of the pathogenesis and the sources of transmission of visceral leishmaniasis. The high definition risk maps are not readily available, and the factors linked to a fatal prognosis need to be better defined. Turning to diagnostics, the sensitivity of rapid diagnostic tests is still a challenge in certain regions, including East Africa. The deployable test of the cure for visceral leishmaniasis also needs further research. It's noteworthy that the work of LEAP and other collaborators has led to a reduction in treatment from 28 days to 17 days. However, the short course, which is first treatment, is not effective in East Africa. Although this is available in Southeast Asia, we need more research around this to see what are the effective tools in different contexts. And also treatment are costly, and the earlier speaker again alluded to that. Financial access is a challenge. We require specific skills in some settings. The use of injectables may not be easy to apply, especially at lower levels of the PHC. So again, we need to do more research around that to see what are those tools that can easily be applied at the different levels of the health system. No vaccine is currently available, although candidates are under development. Ladies and gentlemen, the COVID pandemic has hampered essential services for leishmaniasis, including here in East Africa. And in response, WHO issued operational guidelines for maintaining essential services during the outbreak, which have enabled countries to maintain some leishmaniasis diagnosis and treatment of services. And as you know, the Global NTD Roadmap emphasized the importance of crucial innovations and more effective and accessible diagnostics and interventions as vital to speed up progress towards the 2030 targets. Now, I looked at the agenda for this scientific conference, and I noted that we'll discuss these issues during the meeting. And I really congratulate the organizers and also the DNDi and other partners for organizing this important scientific conference. I've also noted that Leishmaniasis East Africa platform aims to strengthen clinical research capacity and provide a base for ongoing inter-country and multidisciplinary collaboration, especially between the East African countries endemic for Leishmaniasis. WHO, also through the Tropical Disease Research Center, has been a long collaborator with the research and development community, and I'd like to appreciate our partnership with the Ministry of Health, the African Union, KEMRI, UNICEF, and other partners here, with whom joint efforts will strengthen the leishmaniasis control and elimination. We remain committed to supporting ministries of health in East Africa. We remain committed to strengthening capacity at subnational level in the East African countries to make sure that we achieve the targets as laid out in the roadmap. And finally, I'd like to reaffirm the World Health Organization's commitment to supporting scientific innovation, research and development, and translating evidence into policy and practice. And I look forward to the outcome of this conference and to knowing how the World Health Organization can further support your efforts. Where can we partner? Where can we support you? And my doors remain open. I wish you a successful conference and deliberations. Thank you so much. And as we say in Kenya, asante sana.
So thank you very much, Dr. Juliet, for that very elaborate presentation. At this point, I want to just take this opportunity to inform the participants that you will not be able to speak during this session, but the chat option is available for you. So in case you have any, clarifications or questions, please post them on the chat section, because they are being monitored and they will inform the Q&A process. So please feel free to do that. And then we are popularizing our conference, so you can go onto Twitter and social media, and you can popularize. Today we are using the hashtag leishmaniasis and the hashtag Africadia. Please feel free to do that. And then hashtag beat entities, as you can see on your screen. Those are the hashtags that we are using to popularize and, just get everybody to know about what is being discussed. Of course, we encourage you to extensively share the experiences with the rest of the world. Now, with us here today, we have Dr. Bernard Pikul, who will be speaking next. But before he speaks, I hope that I'll be able to stay into the end of the opening ceremony session. But after Dr. Pikul speaks, in case I'll not be able to be in, then my colleague, Professor Azrat Hailu, has graciously accepted to complete the moderation of this session. But I hope that I will still be in so that we can complete. I had requested Sheila to stay on because Sheila, you have the responsibility of officially opening this particular conference. So probably if you're comfortable repeating the presentation, well and good, but if not, you will be charged with the responsibility of opening up. It will be our honor for you to open officially this particular session. Maybe you can just do a summary of your presentation, then you open. So over to Dr. Bernard Pikul, who is the Executive Director, Drugs for Neglected Diseases Initiative, that is DNDi, where he has led DNDi since its foundation in 2003. Prior to DNDi, Dr. Pikul was director of the Medicines Sans Frontiers, MSF, campaign for access to essential medicines from 1998 to 2003, a position he took on after that of executive director of MSF France. While working with MSF, Dr. Pikul carried out field missions in Africa, Latin America, and Asia. In 1988, he co-founded Epicenter, an MSF-affiliated NGO specialized in epidemiology. After obtaining his medical degree at the University of Clermont-Ferrand in France, Dr. Pikul earned a master's degree in public health at Tulane University, USA in 2012. He was awarded an honorary Doctor of Laws degree by the University of Dundee in the UK. Bernard Pikul is a member of the Joint Coordination Board of the Special Program for Tropical Disease Research at WHO TDR, and a former board member of the Unitides Medicines Patient Pool. Ladies and gentlemen, I would like to pass it over to Dr. Pikul. And Dr. Pikul, please take it over when you're ready. Over to you, sir.
Thank you, Dr. Sultani Matandechero. Good afternoon, dear colleagues, dear friends. I'm very happy to be with you today. Unfortunately, not physically present in Nairobi, that I will visit very soon, but I will be close to you in the next 2 days. I'm very happy to take the floor after 3 of the founding partners of DNDi, because I can mention that Professor Kariuki is representing Cambridge that created DNDi, as well as Roland Kaya from Médecins Sans Frontières, and Juliette Nabionga that represent the WHO. The three institutions have contributed to the creation of DNDi in 2003 and continue to be major contributors and major supporters of DNDi. So I would like to just also convey my special thought to our colleagues in in Sudan that unfortunately again are crossing a difficult period. So my pleasure is to be with this LEAP community, this LEAP group. I've been lucky enough to be part of the initial development of the LEAP in Khartoum. And I want to just describe all the progresses that have been accomplished during this period of time. When we started this group, the intention was to develop capacities for conducting clinical research on the field of leishmaniasis. And today, of course, we can measure all the progresses that have been accomplished. A long series of very good clinical studies have been conducted in a network in Sudan, in Ethiopia, in Kenya, in Uganda, changing quite a lot the way we could manage leishmaniasis today. So with an initial strategy that was based on existing drugs, but with improving the regimen with a drug combination, better dosage, better formulation. So here we have achieved several steps. The first step was the combination of paromycin with SSG that now is used in most of the places to treat cases. But since the last few years, a lot of other progress have been accomplished. I could refer to a new treatment for the combination of, for the co-infection of HIV with VL, visceral leishmaniasis. Recent results that will be presented later today or tomorrow during the conference with a combination of paromycin miltefosine that will probably achieve one of the goals that we have from the beginning, was to reduce the use of antimonials, a very toxic drug, to treat leishmaniasis. And I know as well that a very good study is ongoing on a form of PKDL that is a chronic form of visceral leishmaniasis that has a major impact on the transmission of the disease. And I expect that this study will be completed soon and will provide better treatment for this specific disease. So here is really, according to me, the end of an important chapter of the activity of the LEAP, was to conduct all this study to improve management of patients with existing drugs. Of course, combined with an improvement of diagnosis, and some progress have been made also in the field of diagnosis. But in parallel, a second strategy was implemented within the DNDi, but with a lot of partners, academic institutions, pharmaceutical industry, to select new candidates, new drugs for leishmaniasis that could provide a treatment that could be used in a very basic level of primary health care. So here I'm talking about oral treatment, short course treatment that could be used probably in combination, and to transform the management of the disease and to be able to integrate management of leishmaniasis into universal health coverage that will really change drastically the dynamic of control of this disease. And this today is not anymore a dream, because we have today in a portfolio 6 new chemical entities at the stage of clinical development. So of course, some of them will be abandoned because it's part of the game of research and development, but with the 6 new chemical entities plus some others as background, we could expect that in the coming years, we'll have well-conducted clinical studies that will bring new treatment fully adapted to the condition of living of very neglected populations. So this is really the next perspective. And of course, the LEAP network, the LEAP community, the quality of this group will be instrumental for achieving this second objective in terms of research. So I think there is still a lot of perspective in terms of using this network or extending this network to conduct more research activity. But in parallel, I would like also to propose that this network and this group of very committed individuals and institutions will have to invest more on providing access to treatment, diagnosis and treatment for the affected population in all the region. So we have an opportunity today, of course, in very close collaboration with the different Ministry of Health, the different institutions in the country, with the WHO. We have an opportunity to transform access to treatment for the patients. Eventually in places where we have already trained people, where the research has been conducted, but I'm thinking also about other places, extended access to other places, other locations, other countries. Of course, inviting the colleagues from South Sudan, from Eritrea, from Somalia to benefit from these progresses. So here is really the next challenge that should be discussed during this conference, but also should be well documented and well designed in the next strategy of LEAP. So it's really my strong desire to see this group going a step further in terms of research, but also doing more for the population that we are trying to serve since several years. So on this basis, I would like to thank all the participants. I would like to, of course, thank the contribution for the African Union. That is extremely important to have a regional political body supporting this initiative. We need commitment from the government if we want to achieve our goal. So thanks a lot. I would like to wish to all participants a very good, very constructive, very productive second LEAP scientific meeting. Thank you very much.
Thank you, Dr. Pikul. Luckily, I'm still around, so we will be able to proceed. Thank you, Sheila, for staying on standby. And before we invite Sheila to come back on, I would just like to recognize the presence of our colleagues from Sudan. As you know, Sudan is currently experiencing challenges with some of their political situation not very stable. But in spite of that very heavy challenge, our colleagues have still managed to log on, to join us in this meeting. And so I would really like to recognize the presence of Professor Ahmed Musa, Professor El Tahir Khalil, and Dr. Brima Musa, all of them members of the LEAP, Leishmaniasis East Africa platform, who are here with us today. And they are also joined by Dr. Abdelgadir Ali Bashir from the Ministry of Health in Sudan. I'd like to welcome you and to encourage you that these are challenges which are not going to last for very long. Now, before I welcome Sheila to officially open this second LEAP conference, I'd just like to remind you that our keynote speaker was Dr. Margaret Agama Anyetei. Dr. Anyetei is the acting director for Health and Humanitarian Affairs at the African Union. She's a senior medical doctor with a specialty in clinical and neuropsychology. She has extensive experience working with marginalized and vulnerable populations, particularly women and children, and key populations in conflict and humanitarian settings. She has wide management and field experience in various national, regional, and international settings. Over the past 30 years, she has held several managerial positions at national level within the UN system and at the African Union Commission. She holds an MBCHB in medicine and Surgery from Kwame Nkrumah University of Science and Technology, Kumasi, Ghana, a Bachelor of Science in Human Biology and MPhil in Clinical Psychology from the University of Ghana. And at this juncture, I'd like to give it back to you, Sheila, so that probably you can recap and officially declare the second LEAP conference open. Over to you, Sheila Musonda.
Thank you so much. I think I'll just summarize some of the commitments, our commitments as the African Union. So I think just to highlight that we do take note that there's a need for intensive advocacy at political, regional, and national level for the provision of sustainable financing towards development of new technologies in the treatment and diagnosis of leishmaniasis. The African Union and stakeholders are advocating for increased funding towards research and development in this sector. And that as a Commission, we're urging our member states to create an enabling environment for research and development. I also want to conclude by saying that we are committed to the attainment of our Aspiration 1, Goal 3 of the Agenda 2063 of a well-nourished and healthy citizens. We also will continue to support member states to ensure that leishmaniasis is eliminated as a public health problem on the continent. We also work with partners to ensure success is realized to that end. Once more, I thank you for making time to be part of this important conference, and also thank you to the wonderful remarks from all the previous speakers. With that, I would like to declare that this conference is officially open, and I would look forward to fruitful discussions and presentations.
So thank you very much to all our panelists. That has been a fantastic opening session with very powerful messages. I believe this sets the stage for the enchanting and informative presentations that we are going to have over the next 3 days. I personally really look forward to them. And I know that we are transitioning straight into the first session. Probably just for purposes of housekeeping, for those who are requesting for the program, it has been shared with you online. You know, the link has been shared with you. So please just check in your chat so that you can keep up with the sessions as they move along. And now, without any further ado, I would like to hand it back to the organizers so that we can now transition into the next session. Thank you very much, ladies and gentlemen, for your attention, and God bless. I wish you the best during the next 3 days.
Thank you very much, Dr. Sultan, and all previous speakers. I'm Dr. Alfred Obanyizi. I'm from Uganda, with the Ministry of Health, Stand Commissioner on Vector-borne and Tropical Diseases, including the government structure, but also the national coordinator for all NDD programs. My background, I'm a medical doctor with Master of Public Health. So this afternoon, I'm honored to take you through the first session of leishmaniasis prevention, immunology, vector control, and elimination. First of all, I want to thank you. This is my first time to chair a session in LEAP scientific conference, so you bear with me where I may be mistaken, but I'm also learning from you, especially if I don't observe the protocol. We have presenters, actually they are about 6. And I ask the presenters to have their cameras on when speaking, and also have a workshop hashtags, as my colleague said, leishmaniasis, hashtag leishmaniasis, hashtag uploaded here, and hashtag being ND. Microphones will be muted throughout the presentation, but if you need assistance or you want to ask a question, you can use the Q&A or the chat function. The chat and Q&A or chat. Live Zoom session will be recorded for those who were able to attend. But if you don't want to be included in the recording, please simply keep your cameras and microphone off. The Q and the chat is monitored during the presentation. And when it's time for Q&A, the chair or the co-chair will pick the questions and comments from Q&A. Participants are encouraged to interact using these two features. I was supposed to have a co-chair, but I don't know whether he's around. I've not interacted with him, Dr. Musama. However, where it is necessary, with Joy, she will help me. So in our presentation, our speakers today, this afternoon, ladies and gentlemen, we have Dr. Daniel. Dr. Daniel, and he is from World Health Organization, Switzerland. Is the unit head prevention, treatment, and care of neglected tropical diseases control department, WHO. Dr. Dane will take us through towards elimination of visceral leishmaniasis in East Africa. Ladies and gentlemen, join me to welcome our speaker this morning, afternoon, because we are in Kenya, Nairobi, this afternoon, but I know our colleagues in this corner is in the morning. So, Daniel, please, you are welcome. You take us through the towards elimination of visceral leishmaniasis in East Africa. Thank you.
Thank you, Chair, and I would like to thank the organizers of this second LEAP scientific conference for inviting me to make a brief talk on this very key and critical and really timely topic towards elimination of visceral leishmaniasis in Eastern Africa, which I believe, strongly believe, is high time that we all work toward this, the elimination of this deadly disease, which is affecting the East African community for so long time. So I understand, looking at the agenda, probably most of the issues that I will be discussing will be also further discussed in subsequent sections. So please bear with me. I will take you through and give you the overall highlights of this strategy. So can you see my slide?
Yes.
Okay. So East Africa is one of the focus, the three hot focuses or epidemiologically important, foci globally, that visceral leishmaniasis burden is really reported in high number. The first one is the Indian subcontinent. We have in the Americas, the Brazil focus. In the Americas, Brazil is the #1 country, reporting nearly 96 to 98, sometimes even 7% of visceral leishmaniasis cases. However, in Eastern Africa, we have around 7 countries which are reporting visceral leishmaniasis in various proportions. In 2020, according to the WHO weekly epidemiologic report, 34% of global VL cases were reported from Africa. 29% of the global VL cases are from Eastern Mediterranean region, and 16% from the Americas, the Southeast and Southeast Asia region, whereas 2% of the global VL cases were reported from the Western Pacific region and from the European region. When you see the Eastern Mediterranean region, please note that Sudan belongs to the WHO Eastern Mediterranean region. So it is geographically part of the Eastern Africa. However, it belongs to the WHO Eastern Mediterranean region. So it is a country which is contributing to the largest proportion of VL cases in the Eastern Mediterranean region. So in the past, we used to say that the Southeast Asia is the largest foci, or eco-epidemiological hotspot for VL burden. However, since few years, the Eastern Africa has taken over due to the successful elimination program in Southeast Asia. In the 2021 WHO weekly epidemiologic report, and 57% of the global reported VL cases are from Eastern Africa region. In Eastern Africa, we also have the high leishmania HIV co-infection, especially in Ethiopia, between 10 to 20%. We have recurrent epidemics following conflicts, migration, and famine, and concomitant infections, malnutritions, compounded by poverty, are also prevalent and complicate and compound the problem of visceral leishmaniasis. In addition to this, in most of these countries, there is weak national control program and weak national health systems. Diagnosis and treatment, as also expressed earlier by various speakers, is difficult and complex. As you see, the global VL cases trained by WHO regions, there is a significant, there is a decline globally, although in the past few years, the decline is not substantial. However, from 2010 or 2011, we see a steady decline, and this steady decline is driven by the key achievement in Southeast Asia region. In Southeast Asia region, as you see, the major reduction in the incidence of cases or in the number of annually reported cases is in Southeast Asia region. However, in the rest of the regions, as you can see, there is upward and downward trend, and this trend is more or less the same, and there is no significant decrease. This graph, shows it's a comparison of trends in the reported cases in the two regions. You can see clearly from 2005 to 2019, there is a significant decline in the number of reported cases in Southeast Asia region, whereas there are significant ups and downs in countries from the Eastern Africa. The same for VL case fatality rates from the high burden countries. If you see the countries in Eastern Africa in the period between 2014 to 2019, there is either no decrease or in some countries even an increase in the case fatality rate of visceral leishmaniasis. What are the risk factors? There are few risk factor studies, proper risk factor studies in Eastern Africa. However, looking at the various literatures, especially in Kenya, Ethiopia, and Sudan, looking at the few studies available, some of the studies are done during major outbreaks in the region. In general, ownership of cattle, ownership of dogs or animals sleeping under acacia tree and sleeping outside, even during the day or at night, are associated with significantly increased risk in most of the places, including the studies done in Ethiopia. Different surveys also indicate that high level of infection, concomitant infections, are found in dogs. This has been found in Ethiopia. This has also been found also in parts of Sudan. In Sudan, some ethnicities appear to be also associated with a risk of contracting visceral leishmaniasis. In some case control study conducted in southern Ethiopia, also having unplastered walls, which is also similar. There are similar studies also in Southeast Asia, unplastered walls, and keeping animals inside the human dwelling and proximity to termite hills, especially this applies also in northern part of Kenya and southern part of Ethiopia as well. And poor nutritional status were associated with risk factors. In general, low socioeconomic status and also ownership of bed net and knowledge of VL symptoms, low utilization of bed nets have also been associated as major risk factors. In addition to malnutrition, conflicts and mass displacement, co-infection and comorbidities, including HIV/AIDS, have been identified as major risk factors in this region. Looking at the various interventions for visceral leishmaniasis, the region, this sub-region utilizes the following interventions. One is case management. Case management, principally early diagnosis and treatment, is the principal intervention strategy for VL control in the region. And increasing access to health care, improving surveillance, control of vectors and transmissions, and political commitment and some operational studies. What is the current status of these interventions? On case management, diagnosis is based primarily on clinical case definition and rapid diagnostic, RK39 based rapid diagnostic tests. However, the performance of rapid diagnostic tests is suboptimal. In various studies across the region, across the countries, it ranges between 70 to 87%. The treatment is still injectables for 17 days with the combination therapy with suboptimal efficacy. The response of some diseases like HIV co-infection is even much lower. With regard to access to healthcare, there are limited number of health facilities providing diagnosis and treatment services. So most of the VL diagnosis and treatment services are limited to few higher complex or high-level health facilities where access to endemic sites is very, very remote. The health infrastructure in most of the endemic areas or the endemic villages are weak. And there is a high turnover of trained staff even in those facilities, in those designated facilities where diagnosis and treatment services are being provided. On surveillance, the surveillance is also weak. It also varies from one country to the other in the sub-region. depending on the health infrastructure or the particularity of the epidemiology of the disease, because the disease is scattered across the countries, and the structure and status of the national health system, or the way the national health information system is set up. So the surveillance in the region is characterized by incompleteness in general. The vectors, primary vectors are Phlebotomus orientalis, and also to some extent Phlebotomus martini and Celiae. They are exophilic and endophilic, so usually people are infected peridomestically. The vectors are active peridomestically. The other most important feature is there is no formal regional strategy. There is no formal agreement or memorandum of understanding, or no high-level political commitment, regional commitment, in order to tackle this condition. And there is no also a regional level advocacy or social mobilization strategy. In operational studies, many studies have been conducted. There are several studies, thousands of studies from this region. However, development of new diagnostic and treatment, development of tools are development of new tools, and the development of access, issues and the identification of access issues and strategies are really need to be really the primary focus for operational research in order to answer some of the strategic issues to go towards elimination. So on case management, progress is needed for improved rapid diagnostic tests for visceral leishmaniasis, diagnosis test for PKDL, test of cure for visceral leishmaniasis and PKDL, prophylactic and therapeutic vaccines that definitely will help in the elimination endeavor, and better oral drugs for treatment, and hopefully, as Dr. Berna Pekul was saying, we may come up with some new treatments in the near future. That is good news. And with regard to access to health care, I think it is difficult to completely revive or reinvigorate the health infrastructure and the health system in the sub-region. But what can be done now is to integrate VL diagnostic and treatment services within the package of the basic health services. Many countries are developing the universal health coverage and the UHC menu. So all countries in the sub-region, they need to include VL diagnosis and treatment services within their package. Diagnosis and treatment services also further need to be decentralized so that they can be accessible to the endemic area. For surveillance also, effective tools for improved timely detection and response to outbreaks, improved case detection in new foci, simple diagnostics, which are fit for field use at peripheral level, for mapping, for epidemiologic surveillance, for monitoring and evaluation, to assist validation of elimination of local transmissions are also needed. Improved innovative vector control strategy aligned to the IVM strategy, and also the need to institute entomological expertise and capacity is also a critical area that needs to be needed if we are to achieve elimination in the region. Another important area is a high-level regional resolution, regional policy or strategic framework, and high-level advocacy for increased partner engagement. As recently, as you know, some partners like FCDO has left the support to visceral leishmaniasis. We need new partners. We need to engage the international donor community and also the member states for improvement. The WHO NTD roadmap hit assessment for visceral leishmaniasis, as you can see, has identified, like most of the NTDs, diagnostics are really needs to be improved. There are diagnostics, but there are no diagnostic for some of the situations, as I said earlier. But however, there is a need for improved diagnostic tests. and monitoring and evaluation, including surveillance, needs to be improved, advocacy and funding. These are the critical access and logistics. The supply, interruption of supply is another characteristics in the Eastern Africa. So these are the critical gaps identified in the heat map for many entities, including visceral leishmaniasis. The roadmap targets this for reducing the number of including the number of countries validated for elimination as a public health program, which the new definition or for operational definition for VAL is to reduce the case fatality rate below 1%. So, and then PKDL also needs to be addressed, especially PKDL is an issue in Sudan. This is an extract I took from a paper that we are going to publish very soon in Lancet Global Public Health. In this paper, my colleagues and I are strongly proposing a regional strategic approach with a clearly defined phases, like we had for a Southeast Asia region, with an attack phase, with a consolidation phase, and with maintenance phase. The initial phase should be a period for high level of donors and for high level of member states engagement for political support, for resource mobilization support. So the various pillars of the program across case management, integrated vector management, effective surveillance, social mobilization, and operational researches, we have identified various activities that really needs to be addressed and that needs to be, measured using indicators, proposed indicators, and also the challenges that need to be addressed in order to bring the necessary impact and in order really to achieve elimination. Elimination as a public health problem is possible. We've seen it from different regions. The European region has done it. China has done it, even if, in those regions, visceral leishmaniasis is more of zoonotic. In the Eastern Africa region, visceral leishmaniasis is predominantly anthroponotic. It is possible, but it requires high-level regional policy and strategic framework. It requires a strong advocacy for mobilization of international community, the member states, for improved resources, and operational research for innovative approach to improve case management, be it in diagnosis, be it in treatment, surveillance, vector control, including vector surveillance, implementation of integrated platforms using the multi-sectoral approach. Integration and alignment of VL interventions in basic health service package aligned, as I said earlier, with UHC principles are also important, interventions and urgent actions that are required if we are to achieve elimination of visceral leishmaniasis in East Africa. Thank you, Chair.
Thank you very much, Dr. Daniel, and we guess you are able to finish in time. And I think now you have given us all the strategies towards elimination, and I'm sure once we implement these strategies, we'll definitely implement the VA. Now, the next presenter or speaker is Professor Dia, and Professor Dia is the professor in the biology department at the University of Maryland, Eastern Shores. Will take us through unmet needs the knowledge vector control in East Africa. I ask the next speaker to mark time because we still have more speakers. So we should finish our presentation within the time that is allocated to us. So ladies and gentlemen, join me to welcome Professor Leah, take us through the unmet needs, the knowledge of vector control in Eastern Africa. Thank you. Professor, you're welcome.
Hello, good morning or good afternoon, your time. My time here is about 7 o'clock in the morning. Good afternoon. Thank you very much, Monique, and all the organizers for inviting me. It's a real privilege that I get to join you in this meeting and also to share some of the wish list for research in vector bionomics and control for East Africa. I'm glad to see so many people after a long lapse of time due to COVID and a lot of other turmoils. I will start this presentation by talking of sharing the map of visceral leishmaniasis in East Africa, which you really all well know. But the purpose of this is just I want to highlight the areas of the highest intensity of disease transmission, which of course I will be more biased for during the presentation. The 29 to 60,000 VL cases per year, that's the estimate, which may be an underestimate due to lack of reporting in many places, which is characteristic of NTDs. A typical thing about visceral leishmaniasis affects poorest populations and results in high morbidity and mortality. And the area has really diverse epidemiology. And that's not just only by the extent of the surface area of the area itself, but it's due to the fact that this is really transitional area in the whole globe where you have a lot of diverse habitats and diverse fauna and flora, which necessitated a lot of environment. And that's essential thing that we have to bear in mind when we address the issue of the vector control and the epidemiology of visceral leishmaniasis. So we have to tailor-make different strategies for different regions and different populations. Next one, please. And so let us first talk about the who are the population at risk that we need to address essentially. And these are either permanent residents of villages or mobile herders of livestock and seasonal agricultural workers. Let me have the next one. This is just a picture from Eastern Sudan, and this is the village of Berber al-Fugara. And it shows you a typical landscape of a Kala-azar endemic village. And here we have thousands of people. Another picture here I'm showing is of seasonal workers and migrant workers from Northwest Ethiopia. 300 to 500,000 of them come from the highlands to the sesame and sorghum agricultural fields near the border with Sudan. And that's where they contract VL. 2,000 to 3,000 of them get VL. Another high-risk group are the cattle herders in different areas in northern Kenya or in Ethiopia or in Sudan, and of course in the Republic of South Sudan, in the Western Upper Nile region. And that is the most challenging part of the epidemiology of visceral leishmaniasis, as we will talk about it later on. Next, please. So what do we need to know for an effective control of the vectors and the transmission of VL? Next. First of all, we need essential information on the vector ecology and bionomics, and I will cover what is going to be needed. The second, on the transmission cycles, and then we will discuss about what needed to be done about vector control tools themselves that we are going to use, and the need for acceptability and economic feasibility studies to tell us about the behavior of the population. And of course, we will need mathematical models for planning and evaluation of control programs. Next, please. So let us talk about the vectors that we are facing here. We have two vectors, basically. There is Phlebotomus orientalis, which is shown as the white circles here, the white circles, which covers most of the region. It's been found in Isiolo in Kenya, south of the equator. It has been found in all over Ethiopia, and in Uganda there is some places, and also in Sudan. Of course, this is the only vector in Sudan. The second vector in importance is Phlebotomus martini, which is believed to be associated with termite mounds and is found mainly in Ethiopia, Somalia, Kenya, and parts of Uganda. There is another vector that is very close kin of Phlebotomus martini, that is Phlebotomus ciliae, but really very few reports about it. The main issue is Phlebotomus orientalis and Phlebotomus martini. Next, please. I will start with Phlebotomus martini, which surprisingly, very, very little information is known about this vector binomics and ecology. In the last 30, 40, or 50 years, there has been a lot of work being done on Phlebotomus orientalis, and I feel there should be more attention given to Phlebotomus martini. In the old books, textbooks, etc., we talk about Phlebotomus martini as being associated with the termite mounds. But we know for sure there has been a lot of change in the environment in this region, especially and very rapidly. And when you read the recent literature, you find scattered reports about Phlebotomus martini in the last 20 years. And none is mentioning about the termite mounds, and none is revisiting this. At the beginning, when in the 60s, Minter and others, when they discovered about the association of this martini with the shafts of the termite mounds, we thought that that's it. People avoid coming close to the termite mounds. But there is not much known about how the vector is adapting, and insects continue to adapt. And so we have to bear that in mind. Martini, the seasonality is known, is non-seasonal with higher numbers during the rainy season, which is opposite to the situation of orientalis, as we will speak soon. And there has been reports showing that it's mainly sylvatic on exophilic, exophagic. And that also poses a challenge for vector control. Next one, please. Orientalis, on the other hand, a lot of studies has been done in the last 20, 30 years, especially on binomics and ecology. And it has all shown that you can never find orientalis if you don't find Balanitis tree, the one in the top here, or you find Acacia sayal on black cotton soil, alluvial, vertisol soils. And that is a very essential feature of Phlebotomus orientalis ecology. Next one is in the villages, we find it, and we find it in large numbers that fluctuate from year to year. Is rarely found inside the huts or the rooms. And that is a very important thing about vector control, that IRS, indoor residual spraying, is unlikely to work against visceral leishmaniasis transmitted by Phlebotomus orientalis. The resting and breeding sites are unknown, although they are thought to be in the soil cracks, and that needs some research in the future. It's highly seasonal. You cannot find orientalis in good numbers or large numbers, except at the end of the dry season between March to June. Another feature about orientalis, as noted by Lewis in 1951, long time ago, and he noticed that, and he said, it's a quite a fickle species. You come to a place with orientalis, and you find 1,000, and next year you come on the same place at the same time, and you put your traps, and you find nothing. And so it undergoes this dramatic fluctuation from year to year, which explains the seasonality of the intra-annual fluctuation, interannual fluctuation in the numbers of Kala-azar cases. Next one, please. A work has been done intensively in Northwest Ethiopia on association of Phlebotomus orientalis with different animals, domestic animals, and we have repeated this type of work in Sudan. We haven't published yet, but there is now consensus. Orientalis has a high degree propensity to feed on cattle. And that bears some promise actually for vector control, because that means we can use this insecticide treatment on animals. But at the same time, we have to understand that there is aspects of zoopotentiation that can arise due to the use of insecticide on cattle, as has been shown in northern Kenya, in areas of Phlebotomus martini, where a major risk factor that came out of a study is treatment of animals with insecticides, because they may be diverted. So that's an area of research that we need to focus on, as I will talk a little bit later on. Next one, please. The orientalis and martini, they have very clear, good association with environmental variables. In 1995, we conducted a study with colleagues at the Liverpool School of Tropical Medicine, and we were very pleased to find that we could have a map, a risk map for the distribution of Phlebotomus orientalis in Sudan, focused in Sudan, although it's showing a little bit of extension to the outside. And that map, we thought that's it. And we just need higher resolution to go about micro habitat mapping. The subsequent work that came on a paper by late Gabriel Mikhail on distribution of orientalis and martini brought some discrepancies, which means this has to be revisited with new tools. Next one, please. Now let me talk about the transmission cycles a little bit, and I think that applies to both Phlebotomus orientalis and Phlebotomus martini and cycles. And we have to really admit the fact that visceral leishmaniasis in East Africa is a complex situation. It's not only anthropootic transmission. And we have big gaps on understanding the source of the infection. And that should be a high priority for the research in the coming 5 or 10 years. So you see that in the villages, we have orientalis demonstrated transmitting to the human. We have demonstrated that orientalis in the wild also is being infected in large numbers and definitely transmitting to animals. We have sylvatic sites where we find sometimes 20% of the flies infected. So that means there is a sylvatic zoonotic cycle. We found few cases of infection in the mongoose in a short-term study, but this has to be done. We need to know what are the reservoir hosts in the wild. And we need to know the role of human in the transmission, and that we have to do it in real detail if we ever want to develop any mathematical models for prediction of the impact of vector control on the disease. Next one, please. So the outstanding questions on animal reservoir of El Dunuvani, next one, is overwhelming evidence. You could see study by Ibrahim, 1999, on the cases of visceral leishmaniasis in the game warden in Dindin National Park. You could read the old literature, Kirk, 1939, talking about people camping in uninhabited places and coming back with the disease. And up to now, if you talk to the people in the villages, they tell you even years when we have no cases of visceral leishmaniasis here, somebody comes from this animal herder's pack from the forest and he's sick and we get time.
And unfortunately, you have only 2 more time.
Okay, just okay. Next one, please. Next one, I will. Okay, just go fast because I'm not controlling. An important area that we need to focus on the transmission of visceral leishmaniasis among the seasonal workers in Northwest Ethiopia. Next one, please, quickly. In the villages in Gadarif, we need to understand the role of PKDL and VL different grades and before and after treatment in transmission. Next one, please. And these are major questions. I shared my slides with the organizers. Hopefully you can have a look at it later on. Next one, please. Next one. From the knowledge we have about the sylvatic nature of Phlebotomus orientalis, now we have a very powerful tool that we think can help controlling visceral leishmaniasis in Gadarif state. Next one, please. As you see in this paper that we published last year, we have a dramatic drop in the number of Phlebotomus orientalis due to outdoor residual spraying of the fences of the houses. Next one. But this has to be done for the impact on the disease. More work that we need to study on the long-lasting insecticide nets and contact and space repellents. And we have to look at the impact of insecticide treatment of animals on the vector, but that has to be done in terms of zoo potentiation, zoo prophylaxis, larger project. And all this has to be done coupled with studies on the acceptability and economic feasibility of vector control programs. And we need mathematical models definitely for planning and evaluation of control programs. This is my conclusions for the study. Thank you. The time is short.
Oh, that's very good.
Thank you very much.
Very interesting. As you're presenting side by side, I was just speaking more interest and enjoying all the slides. I can see that now, definitely, once we implement what our speakers are presenting here, then we should be able to achieve the WHO roadmap 2030 by making the VL, make sure that there are no VL is no longer a public health problem in the by 2030. So it's very interesting, and I wish we had enough time to go through all the slides. Now, next on agenda is Dr. Abed Legenda Bashir. This is from the Regional Office of Africa, World Health Organization, Republic of Congo. Here, the rich profile is the DNDi medical officer and regional focal person for leishmaniasis, scabies, and other ectoparasites at the World Health Regional Office of Africa. He has over 22 years of experience in health and health-related programs, including 18 years of experience in management of public health programs in various capacities, working with government, international NGO, multilateral agencies, and at national and international level. He has served as medical practitioner in public facilities. He has also worked with MSF, Holland, stroke HIV, AIDS, malaria, Kala-azar project in Ethiopia. He has worked with Family Health International, stroke USAID, as care and treatment officer, as national professional officer for leishmaniasis and an NDD program coordinator. So, my friend, Abed.
Thank you very much, Dr. Alfred. And
yes, you are welcome. You are the next on the agenda. Can you take us through the structuring, the political agenda for leishmaniasis in East Africa? Thank you.
Thank you very much. Good morning, good afternoon, everyone. And I would like to thank the organizers for giving me this opportunity. So my talk will be on structuring the political agenda for leishmaniasis in East Africa. And in fact, most of it has been covered by our colleagues, mainly Dr. Daniel. So it's mainly to focus on the effort towards strengthening the national program for leishmaniasis with national ownership, and then the impact under the principle of universal health coverage, which at least ensures sustainability of the real program, and then in fact with the strategies that have been highlighted by my colleague, to have an initiative, a regional initiative, a regional approach for the elimination of visceral leishmaniasis and the control of cutaneous leishmaniasis in this specific high burden foci, where has its own specificity and then in fact complexity for visceral leishmaniasis especially. So as you can see from my slide, so the new NTD roadmap, which was launched last January, and with in fact fundamental shift on from the previous NTD roadmap, mainly highlighting 3 areas, and then I'll focus on mainly on the third and the second one. First being the current NTD roadmap 2021-2030 is mainly focusing on impact and measuring impact rather than measuring process and inputs, which is a shift from the previous roadmap, and also in having a cross-cutting approach, holistic approach for the prevention, control, and elimination of targeted NTDs in the countries. And then mainly on the third strategic priority or pillar, the operating model and culture to facilitate country ownership, which is a great emphasis being provided in this area, where countries should have high level of ownership of the program, much improved from the previous one, because at least there is some initiative from national government to take over and lead the program, but still much remains to be improved. And this has to be supplemented with funding, because we don't see adequate funding by national government for the control and elimination of this disease. So a lot is required, a lot of advocacy has to be made in this area. And also empower at the different levels of government to take responsibility and lead the program, and also provide the right support and coordinate partners in the endeavor for the achievement of the roadmap. And also to integrate the multi-year strategic plan with the national health strategy, to have an effective control strategy developed and implemented.
Hello, Dr. Deji, please put
yes.
your presentation on slideshow. You can't see what you are presenting.
It's not in slideshow?
No.
Oh, sorry. So can the organizers share the slide so that I can stop from my side? Just enter.
Yes.
Okay. So
it's there.
yeah. So next slide, please. Next slide. And then so on cross-cutting approach for NTDs, which is very highly highlighted, in fact, in the recent roadmap, integrating, across all NTDs, because there are several NTDs in the country. So, we have to integrate our implementation to have, an efficient use of available resources, and then to have a high impact on our intervention, and also mainstreaming within the national health system with approach that we have, leaving no one behind, the principle of universal health coverage. And also because the entities should have also support from other stakeholders and also other government offices, which requires an effort from everyone so that it can be implemented properly. So it has to address all this. So to improve priority in the national health agenda, and then that has been mentioned by our colleagues, East Africa being the high major foci currently for visceral leishmaniasis with its peculiarity, and also in some areas we are also getting reports that the disease is spreading, and probably this may be attributed to the improved surveillance system in countries. But again, it has to be taken cautiously because we are hearing reports from countries that disease is spreading to new areas. So a lot of effort has to be made to properly evaluate and support the program. And also, as you know, disease being epidemic prone with high case fatality for visceral leishmaniasis, and also with severe deformity for cutaneous leishmaniasis. And this is also one of the big challenges that we are facing in relation to leishmaniasis in the region. And as I've been mentioned also, low visibility of leishmaniasis in the national health agenda, being neglected from funding and also from research, and then several areas which requires a high level of attention so that we can improve also in this area. And limited option for diagnosis and treatment and then diagnostics. So to improve visibility and government commitment for this, achieving the roadmap pertaining visceral leishmaniasis and cutaneous leishmaniasis, with a new roadmap to strengthen the universal health coverage approach, and including visceral leishmaniasis and cutaneous leishmaniasis in the national health agenda, and improving access to diagnosis and treatment for leishmaniasis. And also one of the advocacy tools that we can use to advocate with national program and in fact stakeholders is the celebration of the World NTD Day, which is now in fact officially endorsed by the World Health Assembly to be celebrated every year on the 30th of January. And this could be a very good tool to advocate for improved leishmaniasis control intervention. And advocacy for inclusion of leishmaniasis in the list of NTDs, and now which is now becoming, in fact, a good approach for countries, because in the past, even leishmaniasis was not included in the national NTD master plan by countries. And then as countries are embarking in developing, the previous slide, please, embarking on developing new NTD master plan, we should put effort in fact, also highlighting all the relevant activities that could help implementation of the leishmaniasis control activities in the countries. Next slide, please. And access to treatment and diagnosis has to improve a lot. And again, on the same note, improving national ownership and involvement of community in the intervention program should be improved. And also funding in the various areas for the control of leishmaniasis and also in research has to be strengthened by the national program. And strengthen partnership to achieve leishmaniasis target, where VL is for elimination and then CL is for control. So we have to work a lot. And so there is a lot of achievement. We are in fact behind. And then this requires a lot of effort to achieve, the set, in fact, also ambitious targets that we have with the new roadmap. And monitoring the progress of NTD implementation through the key performance indicator, and then NTD scorecard is very important, so that national program should be closely monitored and then supported. And also ensure sustainability of the leishmaniasis control program, so domestic funding, and also embarking in integrated approach for control, and also into providing the institutional capacity and the inclusion of inclusion of training and leishmaniasis in the medical curricula, which also improves the capacity of the member states in controlling this disease. And also to strengthen partnership to achieve leishmaniasis target in line with the roadmap and supporting countries in developing guidelines, at least currently using another combination treatment, which is short and effective regimen, but again seeking for better diagnostic and then treatment options, which can also be an area of focus. And to engage with drug regulatory authorities for inclusion of VL commodities in the essential drug list is because some of the countries in East Africa, in the recent being Eritrea, just endorse the inclusion of leishmaniasis in the essential drug list, so that has to be also given emphasis in the future. And also sustainability framework for implementation of NEPD, and also improving cross-border collaboration, because we need to have strengthened surveillance system, case detection and management, and other control interventions through strengthening our cross-border collaboration. Because some of the countries be reporting several cases being receiving from other countries. So I think information sharing and then improving in that area is also an area of focus. Thank you very much. This is all I have, and over to you, Dr. Alfred.
Well, thank you very much. Thank you very much, Dr. Ash, for finishing time. Very interesting, and I think it's good for us, one, the Ministry of Health, and also the partners who are supporting us in the nation of NDP and visceral leishmaniasis. You can see that we have a lot to do, but now with all this rich information, I'm sure it will be easy for us to relate NDP as is stated in the roadmap 2030. We just need to share those slides, very interesting, and I feel now we're doing more and more in the elimination of the VM. Yes, is the exit that has been narrated a long time. And I think every day we learn new things. Learning is a continuous process. So on the agenda is the next speaker is Dr. Jane from WHO Switzerland. Jane, you will forgive me sometime. As I said, it's my first time to interact with most of these people. So where I don't pronounce their names well, kindly forgive me. This time I will be able to pronounce your names. I don't intend. So the Dr. Jean is the medical doctor with public health background, working in the field of NPD for the last 20 years. Is currently in charge of the visceral leishmaniasis program, the Department of Control of Tropical Diseases in the WHO headquarters. So, ladies and gentlemen, join me welcoming Dr. Jean. Take us through the prospects of the visceral leishmaniasis elimination in Eastern Africa, applicable lessons drawn from the Southeast Asia Generation Initiative. Dr. JD, you are welcome. Thank you. Dr. Lee, please go ahead.
See, Dr. Chen has written in the chat box. He says that he is logged in as an audience and not as a presenter, so someone can assist him.
Okay. So who has his presentation? Please go ahead. Go ahead and present. You are on. Your slide is on.
Hello.
Yes.
Thank you so much, Mr. Chair. And sorry for this delay. First of all, my sincere thanks to the organizers and colleagues for accepting this interesting work. And thank you to all the colleagues who have contributed to this work. So with the launch of the new NTD roadmap 2021-2030, there was a need to know more about the prospects of visceral leishmaniasis elimination beyond Southeast Asia region. As we know that currently the Southeast Asia region is the only WHO region where VL is targeted for elimination as a public health problem. And with this, the elimination initiative, it started in 2005, but before that, a lot of preparatory work and a lot of operational and implementation research was carried out. Therefore, there was this need to understand what are the lessons learned from the VL elimination initiative in Southeast Asia and what can be applied in the other contexts, particularly in East Africa. So I will discuss about that with the following outlines about objective, what was the method, and what are the lessons, and what are the recommended pathway by different stakeholders. Next, please. So as I said, the purpose of this activity or this exercise, which is still work in progress, was to draw lessons from VL elimination initiative from Southeast Asia and understand what lessons can be used to improve elimination strategies in East Africa. So that was the main objective of this work. Next, please. So for that, we hired a consultant to our team. We did literature search to understand what information is already available, what are the challenges which is already known. And basically, we wanted to know that what key stakeholders feel about the success, the challenge, and the replication of the similar initiative beyond Southeast Asia region. So for that, we prepared the guide based on qualitative research, and we interviewed around 25 stakeholders ranging from Ministry of Health, directors of the program, NTD programs, partners, experts, donors, and the 3 levels of WHO colleagues, both in Southeast Asia and East Africa. And this is still continuing. We also categorize the observations and recommendations into different health systems building blocks so that it is easy to structure the observations. So as of 2020, next please. As you can see, next please. Thank you. So as you can see, the Southeast Asia region is contributing less than 20% of cases, and the major hotspot or the eco-epidemiological focus is now in East Africa setting. Around between 10 to 15,000 patients, estimated patients we are expecting from these major endemic countries. Next, please. So when in 2005, elimination initiative was launched in Southeast Asia region. As you can see in the pie chart, the red colored pie is of Southeast Asia region, which used to contribute around 70% of the VL burden globally. And in 15 years time, this red pie is now reduced to 18%. Therefore, there has been a huge significant improvement and huge success in terms of reducing the VL burden in those high endemic countries. What is interesting is here that in terms of numbers, although the region of Africa, there is a decline, but it still continues to harbor a major burden of disease globally. Next, please. If we look at the three major endemic countries in Southeast Asia, which had signed the Memorandum of Understanding, and the national program took the initiative and the leadership, if we look at the right-hand side upper graph showing the disease trend of last 14 years in India, we can clearly see that there is a decline from a peak of 44,000 to less than 3,000 cases in 2019. And in 2020, it has gone down further to less than 2,500 cases. So in the region, there is a more than 90% decline in disease incidence. The same story is can be seen in other two countries, Nepal and Bangladesh, where a proportionate decline in disease burden is clearly visible due to this elimination initiative. Next, please. So with this initiative in place, several things have happened, and the outcome is that as of 2020, 98% of implementation units have achieved the elimination threshold in the region. These elimination units are the sub-district level in India and Bangladesh, and the district level in Nepal. Now, countries in the region are gearing up towards the new NTD roadmap target, which is less than 1% case fatality rate due to primary visceral leishmaniasis. And that is the new global VL elimination target as a public health problem. Therefore, we asked the stakeholders that is it feasible to support a similar regional initiative other than the Southeast Asia region and focusing mainly on East Africa, which includes Sudan in the region of Eastern Mediterranean and in WHO. And that was our primary objective and the focus of discussions with all the stakeholders. Next, please. So all stakeholders, they mentioned about disease dynamics, and as we have listened to previous speakers about the complexities, but within that, what was noticed and what was emphasized about within the given challenges, it is still possible to launch the elimination strategy and the initiative, despite the fact that patients in East Africa, they need more ambisome, which is a second line treatment regimen. It's not the first line. There is long treatment, all the health systems challenges, and there is no drug donation program for the first line combination treatment, or there is no donation for diagnostic tests for East Africa. So within these known and given challenges, following were the recommendations. Next, please. Can you move to next slide, please? Yes, thank you. So these are the lessons. The first is put into leadership, stewardship role and the governance role of ministries of health. And it was emphasized by stakeholders about the strong political commitment of endemic countries, which actually led towards drafting of the Kala-azar elimination program in the region. And then there were certain structures which were put in as institutional mechanism to not only guide the program, not only allocate resources, but also periodically monitor the progress, milestones, and challenges, and give its recommendations. So the first such mechanism was a regional alliance in the form of a memorandum of understanding signed by the health ministers of Bangladesh, India, and Nepal in 2005, which was supported by WHO, and creation of a regional technical advisory group, which is considered the highest technical body at the regional level, which supported the national elimination programs in all the countries. In 2014, 2 more countries, they joined this initiative, Bangladesh, Bhutan, and Thailand, where sporadic cases are reported, but they are also part of this regional initiative. There were other mechanisms like strong coordination with the research institutes. The capacity of local institutes were built through the partnership with the Center of Excellence abroad and the leading experts worldwide, with all the monitoring parameters, indicators in place, so that everything is goes by the indicators and everything is monitored timely. Next, please. The health financing, the major role of the ministries was to provide the domestic funds, and that is the backbone of this elimination initiative in Southeast Asia. Not only that, other external partners and donors, they got encouraged with the involvement and allocation of domestic funds by these ministries, and they also took part in this World Bank, the UK FCDO contribution, the Bill and Melinda Gates Foundation. All organizations, they supported not only implementation, but also the operational research aspect of the elimination. There was a dedicated workforce at most of the levels, at the implementation levels, at the regional and central level, and field supervisors, depending on context to context, country to country. And that was one of the important aspects toward of this success. Also, what is another aspect, another important aspect was the availability of services close to patients' place, and the referral mechanism in all the 3 countries, and ensuring the uninterrupted supplies of various medicines and diagnostic tests. In addition to that, the social and economic growth, which improved the social status, and similarly the health infrastructure which this improved the access to treatment and services in these places. Next, please. So surveillance, it goes without saying that with all the improvements, this was also strengthened at all levels with the improvement in health management information system and various surveillance methods used not only to detect cases early, but also detect outbreaks early, investigate it, and for appropriate response mechanism, along with the integrated intersectoral collaboration among various stakeholders, which played a major role in the success. Next, please. Thank you. So this is the second last slide. This also, there was a major thrust on the operational and implementation research. For example, there was a VL elimination program monitoring and evaluation indicators formulated. Also for vector control recommendations, and the indoor residual spray toolkit was prepared. The single dose trial of Ambisome was organized, which led to the adoption of the single dose, single day treatment of Ambisome, which significantly reduced the out-of-pocket expenditure for these patients, families, and communities. Therefore, operational research also played a major role in the design of the strategies and implementation of program. Next, please. So this is what stakeholders have recommended, and I'm presenting as the recommendation has been analyzed, that member states are accepting and updating their national guidelines, NTD master plan, with incorporating the new VL target for elimination as a public health problem by 2030. And then this should be presented as an advocacy tool in various platforms like World Leash, 7th World Leash next year, the African Union, with all the donors, and then preparing a technical guiding note for feasibility operational research to demonstrate the feasibility of this approach. And then WHO supporting the ministries of health, the national program managers, along with the various levels of WHO in collaboration with the Ministry of Health leadership. Member states request this agenda to be part of the WHO's regional committee for discussion, and then this elimination initiative can be launched accordingly. Next, please. So I thank Dr. Merce, who was supposed to present this. She prepared the first set of slides, and then I modified it. And acknowledgement and thank you to all the Ministry of Health colleagues, partners, donors, and WHO 3 levels for this work. Thank you so much. Thank you, Chair.
Thank you very much, Doctor, for that very nice presentation, very interesting. I was very excited, especially when he talked about the new drug, the posting, because it's a new drug for VL that was discussed yesterday. So I'm happy that the WHO has already picked it. And they have also talked about the drug combination and the drug that we discussed yesterday. So I thank you very much that you have really mentioned it and really we are all excited and the DNDi that we have tried to develop this drug. So I'm happy that the WHO is in support of this initiative. And I thank you very much for finishing the time. We gave you more 5 minutes. And now next on the agenda is the Dr. Carlo Garudu, the NDD Fund. Carlo is the Vice President. End Fund, a program at the End Fund. Among other roles, she has served as the Chief of Party for the state, funded the integrated health project implemented by ITRA Health International in Eastern Uganda, where she provided technical, financial, and overall managerial oversight across the districts and in over 600 health facilities. Received her doctorate in public health and master's in public health from Boston University School of Public Health. And also Bachelor of Science in Botany and Zoology from Jomo Kenyatta University of Agriculture and Technology in Kenya. So Carlo is welcome. And as we know that you have actually stepped in at the right time to fill the gap that the FCDO and the corona agent left. So you will take us through the consented Liverpool elimination of
Okay, thank you, Dr. Mbangisi.
You're welcome. Thank you.
Thank you, Dr. Mbangisi. Just let me know if you can hear me. Okay, thank you. I'm excited to be here. Again, I'm Carol Karutu. I'm Vice President of Programs at the End Fund. And I will spend the next few minutes walking you through my presentation, which is entitled A Concerted Endeavor for Elimination of Kala-azar in East Africa for 2030. I will not go through a couple of my slides, which were mostly on epidemiology, because Dr. Daniel and others before me have done a really good job. But I will just begin by talking about our goal and the goal of the program that I'm going to talk about today, which is called the East African Visceral Leishmaniasis Initiative, is really based on WHO elimination target. So our goal, we're working to eliminate, to ensure we have a case fatality rate due to VL of less than 1%. And to do that, we are looking at treating about 100,000 population cases every year. Okay, so where do we come from? I think it's good to talk about the history of implementation of VL control activities in East Africa. And as you all know, the VL activities before 2014 were supported in each country by different implementing partners. That could have been DNDi, Find SOS. And as of between 2014 and 2019, we had the Color Core project that supported Ethiopia, Sudan, and South Sudan, among other countries. And then between mid-2019 and 2021, the UK government funded the ASCED program, which supported VL activities in 5 East African countries: Ethiopia, Kenya, South Sudan, Sudan, and Uganda. During this point, through WHO funding as well, through FCDO funding, WHO exclusively provided the diagnostics and the medicines. This was done in collaboration with local governments, where the local governments, ministries of health and entity divisions and departments worked on the coordination of the VL activities. They supported the development of treatment guidelines. They ensured compliance of treatment, integration of activities into primary health care, And as a result, the VL activities continued to be implemented. And obviously through this period, the coverage was between 25 to 40% of those cases suspected. So already you can see there was a gap. But the major gap occurred in April this year when the UK government and the FCDO cut funding for 90% of NTDs. And as such, the ASCEND program was 100% affected, and that made as a result, the East Africa VL program was also affected. So what happened was two donors, Elmer Philanthropies and Margaret McNeil Philanthropies, MACP, came forward and put some money to implement a VL the East Africa VL initiative, whose goal, as you can see, is to contribute to the global target, which I mentioned a little earlier, to eliminate, if we can, and control VL as a public problem in East Africa. The negotiations, WHO will continue to provide the diagnostics and medicines. Implementation is by the END Fund, who I work for. The timeline is 3 years, starting August 2021 through to July 2024. The countries that are covered are Ethiopia, Kenya, Sudan, and South Sudan, and Uganda. And as of August and September this year, we were able to bring on board country-specific implementing partners, and these are FIND, supporting the Kenya VL program, IMA supporting the South Sudan VL program, Crown agents supporting the Uganda and Sudan VL program, and then in Ethiopia, the implementing partner is the Ethiopia Federal Ministry of Health. So what does this program intend to do? So we have structured the VL program in 3 phases. The first phase is the emergency phase, which, as I mentioned, started in August. And the idea was to ensure that there's a continuity of services. So as such, treatment and diagnosis is not interrupted, even with the withdrawal of FCDO. We are also looking within this phase to advocate government leadership and also ownership so that peace continues. We are looking to work at coordination, again spearheaded by the government and other health ministries. We are looking to really begin looking at integration of VL activities, or rather strengthening the integration of VL activities into primary healthcare, working on streamlining the partners and partnerships that we work with. And even more so, within this emergency phase, we're looking at conducting an implementation baseline so that we know where we stand and the gaps, so that those can advise, the results of that can advise where we move to in the next phase. The next phase is, we are calling it the intermediate consolidated phase, and this will be between 9 months and 24 months. And through this, we will look at doing things that are more in addition to the treatment, and many of the activities I mentioned in the emergency phase is looking at a regional strategic plan for elimination of VL, if we can, creating or trying to see how we standardize national and regional information systems for all components of this disease, and then looking to see how we improve collaboration and have joint cross-border activities. So this meeting comes in very handy. And also looking at a framework of collaboration with all the players, and that includes non-VL implementers. And that will lead us now to the third phase, which is the sustainability phase. And these will be between the 24th and 36th month. Like I mentioned earlier, this is 3 years, so 36 months. And within these 36 months, one measure of success is if we can begin to transition VL control activities to governments and specifically into primary healthcare systems to have really 100% of integration of VL activities into the national health plans and budgets. And again, address the cross-border transmission dynamics. And finally, governments, streamlining stakeholder activities for effective partnerships. So that's the project as we see it. However, we are very aware, and I believe the speakers that have come before me have very much spoken to these gaps. But even as we've started, we've just been on it for the last 4 or 5 months, we notice very much that the national surveillance systems are not functional, or really not fully functional. And as you can see, even today, a lot of the data that we reference is 2012 epidemiological data. So the question is, what do we do between now and in the next couple of months to ensure that we have more recent data and updated data that we can speak to and not speak to 2012 data? Again, there isn't really a clear pathway for elimination of VL in East Africa for the reasons that have been talked about today: entomological reasons, cross-border reasons, policy reasons, treatment reasons. They've all been addressed by those who spoke before me. And then government funding is often lacking, or where it is actually very limited and even unknown. So we would like to actually support where there is already government funding. I visited Ethiopia and I was really, really impressed at the facility that I visited, because almost everything was free. There wasn't any donor there apart from the drugs that were being provided. And the government was doing its job by making sure that those who had VL actually got the treatment they needed. Then cross-border surveillance is lacking. And so how do we improve that? That's the other gap. Vector control activities are limited. Again, today we've talked a lot about the incomplete data, or data not fully integrated into the health management information systems, or DHIS2. So how do we work to improve that gap? And finally, the issue of diagnostics and medicines, where we find consistent stock out, erratic supply. How does that get improved? And finally, there is, as we all know, the uncertainty of the RK39 production. So what advocacy do we begin today to ensure that come 2022 May, that the RK39 can still continue to be produced, so that we can continue to test and diagnose those that have VL? Thank you for listening to me.
Thank you very much, Carol, and the very good presentation. We, the government, were worried because we saw that your intervention is short-lived, since we had only 6 months, 8 months. At least now, you have assured us that it will take us up to 2024, means we still have 3 more years. And I agree with you, the gaps, as you have mentioned there, it's actually, you know, everything. The other challenge is that you have granted another partner, so make sure that your vision and your goal is really achieved, so that they deliver on what you set out to do. Now, without wasting time, we have another speaker. I don't know whether he's around, and this is none other than Dr. Frederick Siri from London School of Hygiene and Tropical Medicine. And Dr. Frederick is a PhD holder, partnership manager, the Global Vector Hub based at the London School of Hygiene and Tropical Medicine. He is involved in building and managing stakeholders relationships across the vector control community, resource users, data providers, and the industry supporters. Before joining London School of Hygiene and Tropical Medicine in 2019, Frederick worked in the population health system at the Wellcome Trust. Frederick studied biology at the University of Germany and the University of New South Wales, Australia. He has a broad background in various aspects of medical entomology and mainstream interests include vector biology and ecology, global health, science writing, and open access. So Dr. Frederick will take us through the global vector hub building entomological capacity worldwide and improving epidemic preparedness. Dr. Frederick, please, you're welcome. Ladies and gentlemen, join me to welcome Dr. Frederick. The floor is yours, Dr. Frederick. Thank you.
Thank you very much for this very nice introduction. And again, it's a very great honor to be here and to be given this opportunity to present the Global Vector Hub and to demonstrate to you how we can contribute to your efforts. Can you see my screen?
Yes.
Excellent. So the aim of the Global Vector Hub is really to build entomological capacity worldwide and to improve epidemic preparedness. And as was said in the introduction, we are based at the London School of Hygiene and Tropical Medicine in the United Kingdom. And the Global Vector Hub has been developed in collaboration with our partners at Arctec International and the Global Health Network at Oxford University. To reiterate, the global problem of vector-borne diseases is that over 80% of the world's population is at risk of vector-borne diseases, and 17% of the global burden of communicable diseases is due to vector-borne diseases. Just to give you a few figures, over 400,000 people have died of malaria over each of the last few years, and about 400 million dengue fever cases are being reported every year. So the Global Vector Hub aims to be instrumental in the elimination of vector-borne diseases worldwide, and we aim to bring together researchers, health workers, and really large on a global scale and cutting across disciplines, diseases, and vectors. So we aim to be the first port of call for different groups of stakeholders. We want to build a community of practice by providing a platform for open and transparent data sharing. We really want to build capacity to improve preparedness in outbreak situations. We aim to connect vector control professionals, and we want to reduce vector-borne disease incidence. In the context of the COVID-19 pandemic, we decided to launch an early version of the Global Vector Hub, so-called Global Vector Beta, in June 2020. With a fully functional version later to follow later this year. This beta version already includes some resources and networking features and really provides quick access to essential information that users were found to be lacking in the context of the COVID-19 pandemic. And we focused on 4 different groups of diseases, including malaria, arboviral diseases such as dengue, Chagas disease, and also leishmaniasis. So this version is already live if you follow this link. And the fully functional version will include many more features, including resources, data, networking features aimed at capacity building, and also global directory of training courses in medical entomology. And I will explain this in a moment in more detail. To give you an idea of the different options that we will have, this is a repository of resources, of accurate and up-to-date resources, including training and educational materials, guidelines for vector control, research tools, information packs to support training of staff, and also the control of vector-borne diseases more generally. To give you an idea, we have at the moment over 300 resource documents already available, and the top 5 include the WHO's Global Vector Control Response 2017 to 2030, which is really such a fundamental document that informs all our planning and our strategy. Also, a study that we conducted last year on the impact of COVID-19 on vector-borne disease research and control operations, and I'll come to that in a moment as well, and some further tools and resources. We're also going to implement a worldwide network of users from different groups and different stakeholders, where they can share their background and their expertise. can actively participate in online discussion forums and collaborate on future projects. Likewise, there will be sections on funding and employment opportunities, which should also help to improve capacity building and improve the retention of staff. To give you an idea about the data, I'm afraid I only have an example here for Aedes mosquitoes, because we don't have very many data sets yet on leishmaniasis vectors on sandflies, for instance. So this, for instance, would give you an idea about the data sets we've collected from the literature on the yellow fever mosquito in Colombia. And a similar feature would also be included for other disease groups like sandflies, for instance. We're also aiming to link resources and initiatives that are already out there and active in the field. So we are backed by many key partners within the vector control community, and we act as a central platform, bringing together data and resources from multiple sources for health workers and researchers to access in one location. And this should help then to improve closer collaboration between different groups and initiatives, and also help to identify knowledge gaps, and we can demonstrate that impact is made and shared across every region. In terms of capacity building, we were also heavily involved in developing a massive open online course on vector-borne diseases and vector control that was launched last year together with ARCTEC, the LSHTM, Liverpool School of Tropical Medicine, and IVCC. We have had over 4,500 registered users so far, and the feedback has been incredibly positive. And the link is still open, so if you want to participate in this course, you can do so. As I said, we also launched in January a global directory of medical entomology training courses, which had been developed in partnership with the Special Program for Research and Training in Tropical Diseases, or TDR, and our colleagues at ARCTEC International. This new resource will strengthen the capacity of scientists fighting neglected tropical diseases and other vector-borne diseases. And we're really pleased with the feedback that we've received so far. At this point, we include 126 training courses in medical entomology from 32 different countries and in 10 languages. And this directory is already live on the website. So feel free to have a browse, have a look around, and give us your feedback. You can easily filter for different options, such as the country, the language the course is provided in, any other keywords, and learn more about the different options there. And we're always aiming to continue maintaining and improving this directory. So if you have any training courses you would like us to add, please do get in touch. So some feedback has been really, as I said, has been really positive. So Dr. Mwele Marcela from the WHO Department of Control of Neglected Tropical Diseases has been enthusiastic, as was Dr. John Reeder, the director of the TDR program. In addition, we published an opinion article last year calling for a concerted and improved global vector control efforts in the face of the COVID-19 pandemic. This was included a global coalition of vector control experts from across the globe and has been widely viewed and cited by now. We also hosted an online workshop on the impact of COVID-19 on global vector control efforts, again in collaboration with the Global Health Network, and this was attended by over 400 participants from over 60 countries. And we had panelists from the World Health Organization, the Kenya Medical Research Institute, the Puerto Rico Vector Control Unit, and the London School of Hygiene and Tropical Medicine. And again, this workshop has been really successful, highlighting the gaps in the knowledge and in capacity, but also helping us to formulate a unifying strategy for vector control efforts. As I said, we also conducted a survey last summer to establish the impact of COVID-19 on global vector control efforts, including how different sectors and stakeholders are affected, which types of vector-borne diseases are most strongly affected, what are the knowledge gaps and lack in communication, but also how to develop robust recommendations for future epidemic preparedness, and also identify common narratives and experiences. This report is available on our website, and it has been shared with many agencies, including the WHO, NGOs, and other stakeholders. The key finding here is that the large proportion of the interviewed of the respondents reported a severe impact on their own work due to COVID-19. And they also felt that COVID-19 affected vector-borne disease research and vector control operations in general greatly or extremely. So I think this is really across the board. So we had respondents from over 150 countries, I believe, 120 countries. And this has been really a universal impression that we gathered. And that brings me to the end. I'd like to thank my colleagues in the Global Vector Hub team. We are led by Professor James Logan, the former head of Department of Disease Control at LSHTM and the director of the Global Vector Hub, and our colleagues at Arctech Innovation. I would like to invite all of you to follow us on social media, particularly on Twitter, for any news and updates that we publish several times a day. I would like to invite you also to register yourself or your work or your organization by following this link. And also, if you're interested in having your training course featured, or if you have any other question, please do get in touch by sending us an email. And with that, I'd like to thank you for your attention and happy to take any questions. Thank you very much.
Thank you very much, Dr. Bradley, for that interesting presentation. And now I'm sure my colleague in the house have been following everything and enjoying every slide. So now we are almost at the end of the session, but we still have several questions. And now the floor is open for questions. If you have any question, please now you can ask a question, and then the speakers, the previous speakers can answer your questions. Also, I'm sure there are also questions in the chat. Some have been answered, some are still there. I will ask my colleague John, maybe read for us if there are questions in the chat that have not been answered. I thank you. So now the floor is open for discussion. Thank you very much. I've been informed that there are no questions in the chat. It means everything has been clear. But in the audience, people who want to ask questions to specific individuals. So the floor is open for questions, discussion, and comments. Thank you very much. It's like there are no questions, everything has been clear.
I have a comment.
Yes, Professor, please.
Yeah, just I have a comment. Since now there is this momentum for elimination, I really think that it's been bad luck that comes after this 2 years of COVID-19, which has impacted the treatment and diagnosis and the number of people reporting to the hospitals. So whenever I find a chance to voice this concern, I really like that people should take with a great caution any numbers of cases reported for 20 and 21. There has been issues of getting drugs to the treatment centers. There has been issues for patients coming to treatment centers, and all this data that goes to the DHIS will depend on the hospital reports, and it's really, really underestimated. And I'm just feeling that it's not going to be fair for planning if we consider these 2 years in our data sets. Thank you.
Okay, thank you very much, Professor. Thank you all for the comment.
Okay, so we've got a comment from Eric, and he says, thank you very much, Professor DNDi and LEAP, regarding research on the zoonotic life cycle of leishmaniasis parasites. You have shown multiple studies from over 10 years ago. Does this mean that research on this hot topic was discontinued in the last 10 years?
To a great extent, it's been discontinued. But I have to mention, in terms of vector control, within the Color Core initiative, we had intensive research on new tools for vector control, not on the transmission dynamics. But part of the GATES project in the northwestern Ethiopia, there was a focus on transmission cycles, and there has been some data. And I hope one day Professor Asrat will manage to publish some data that were collected by late Dr. Tishoma Gabriel on anthroponotic transmission from HIV VL co-infected patients. I'm aware of that, but it hasn't been coming out. So you could see, yes, true. In the last 10 years, very little done on the zoonotics or the anthroponotic cycle. The transmission cycles has been ignored. Thank you.
Okay, thank you very much. Before we invite Dr. Manika, there is another comment here from Dr. J. Maybe you can go ahead, make your comment.
Thank you all the presenters, and big man is more a comment. We want to be directed to, among others, actually the chair. It's a comment regarding the presentation by Dr. J, who made it clear that in the elimination program for Southeast Asia, the national leadership took the lead, the national program, national post-kala-azar program took the lead role while the donors then came in. And I think the challenge here is the national programs for our countries in Kenya, Uganda, Ethiopia, Sudan, ready to the challenge to take the leadership role in the elimination program. So I think that's just a challenge to us, but it is not the donors who will take the lead. The donors will come to supplement. And the leadership should come from the national programs, starting with our own here in Kenya. Don't need somebody here from the Ministry of Health from Kenya, but they should know we expect them to take the leadership role. Thank you.
Okay, thank you very much. Yes, that comment has been taken for advice. Professor, someone say something?
Yeah, this is Asrat. I thank all the speakers for this profound discussion of VL in general. And I have a question for the two speakers, the same question for the two speakers, but before I do that, yes, I do share your opinion that VL is both anthropologic and zoonotic. And I did also note that you did not cite some of the publications around that. So, which suggests there is really wild animal infections in the endemic area. So that's, but also the publications on Phlebotomus martini, the association with thermal cases. I think that has been dealt with quite well. I think with the late Gabriel has done a lot of prospective studies, longitudinal studies, seasonal studies, infection studies. So there has been quite a good amount of data concerning that. Having said that, so my question is possibly for Dr. Carol and Dr. Jane, Saruba Jane. So it's about numbers really. So in setting this 1%, less than 1% reduction in mortality, So one wonders what the current mortality is in visceral leishmaniasis. And in the Eastern Africa region, the main issue is really access. And because of the lack of access, there's then, of course, there's of data on the burden as well. But so how do we arrive at those numbers? I mean, does it mean that the mortality at the moment is 75%? Because the coverage is only 40 to, what was it? The numbers given to us were, I think it was Jane who talked about coverage, which is between 25 and 40%. Does that mean, VL is a killing disease, and yeah, we can of course ignore the self-cure, which is less than 2%, and it means that the mortality is 75%. And so I'm just worried about numbers because those numbers would be used in setting a target for elimination. Thank you very much.
Okay, thank you very much. Maybe before that, we will question for Carlo and the doctors, Robin and Jane. Maybe you can respond to that.
Yes, thank you so much, colleague, for your question. I don't have the exact numbers available to me, but what has been presented earlier by all the speakers about the issue of underreporting ratio, but whatever numbers are reported in the national surveillance annual reports, it is more than 1% in all the major endemic countries in East Africa. And for that matter, around 12 countries which contribute around 95% of the world's visceral leishmaniasis burden. In all those 13 countries, the case fatality rate is more than 1%. And that has been the basis of setting this target. What we aim and what we are expecting that in coming years, this NTD roadmap should act as a very strong advocacy tool where we strengthen services in those remote areas and for those patients, and also reporting and surveillance improves. And if that improves, then we will not only have a better picture of the disease burden, but also the treatment outcomes as well. Thank you.
Yeah, I'd also like to add to what Sarup said, that as for the N Fund and our partners, as we go through the next 3 years, we're very much looking at active case finding, because that's the only way you can catch and diagnose early and limit high mortality rates. So I think that, again, is very much anchored on the fact that we need the diagnostics and in good supply so that we can go out into the communities and really find these cases early enough and not just rely on clinical symptoms to get to diagnosis.
Okay, thank you very much. Dr. Monica has been actually waiting. She has a question. So Dr. Monica, please, the floor is yours. Make your comments. So you have a question, you may ask your question. Thank you.
Thank you very much, Dr. Alfred. First of all, I just wanted to thank all the panelists for the excellent presentations, throwing a light into a lot of issues. My question is to my friend Daniel. Is regarding domestic funding. WHO, you said, is advocating for domestic funding. for NTDs. And in that light as well, leishmaniasis. So I just wanted you to throw some light. What are the, what is WHO thinking? How will this be done? Because I know that most governments have competing interests. Although we know that this is a responsibility of governments to look after their citizens, but with this competing interests and with the pandemic raging, how will this be achieved? Thank you.
Thank you, Monique. Yeah, definitely this is a fundamental question that needs to be addressed. As one of the earlier speaker also said, one of the key ingredients for the success in Southeast Asia, as also presented by Saurabh, is the member states' commitment, the government's commitment. For many number of years in Southeast Asia, the countries were funding most of the activities. Although some countries received funding at later stages of the elimination program. But when the elimination program was initiated in 2005, vector control, case management, including all procurement of supplies, medicines, diagnostics, etc., were funded. Of course, several operational researches were done in collaboration with different academia. The WHO TDR has invested a substantial amount of money in the development of the currently used drugs, be it lambizone, be it miltefosine, etc. The same on vector control tools. So yes, this is key. Now, not only for leishmaniasis, but also for many health programs, the importance of domestic financing has been, critical. Toward this, as you know, now, okay, we have this roadmap. It is endorsed by the member states. The reason for getting their endorsements during the World Health Assembly is to make them, to commit themselves to do, some part of their responsibility in financing these entities. The roadmap document now is launched, okay, started to be implemented. There are companion documents for the roadmap document. One of the companion documents is the investment case. So this investment case is developing some guidance and some tools for countries in order to make countries to show what would be the return if they invest on this kind of fatal diseases. At the same time, to measure accountability of countries, to put some clear indicators to see if countries are putting some budgets towards the different interventions for this. So this is currently being finalized. I hope when it is launched, it would be launched and it would involve all the political high-level instruments. I hope the African Union also will help us in launching to the African countries. The WHO African Regional Committee, I hope, would accept it and also probably kind of pass a regional committee resolution toward that. So there are a number of such endeavors, also additionally other parallel measures by the organization in order to increase domestic financing, in order to also measure accountabilities and also development of accountability framework, etc. So I hope all these things would definitely bring. It's not easy. I understand it's not easy at all because of several competing priorities, as you said, and the coming double burden for our countries. Communicable disease now, non-communicable disease is becoming a huge burden in most of the countries. So it's going to be challenging. However, it's not also impossible. I hope. Because real endemic foci are scattered. It is really possible for this country. It's a matter of commitment. It's a small quantity from the investment they are making for several programs, health programs. it's a minor investment that we are requesting for.
Yes, thank you very much. Been informed that more questions in the chat, but I think the WHO team can answer them in the interest of time, because we still have a poster presentation conducted by Dr. Schlat. But before I hand over mic to him, I want to first of all to thank all of you, the presenters, for preparing very well. It has been interesting. It is here in the afternoon, but the war room is everybody is awake, and it has been very interesting. And also want to thank my colleagues here in the room and even those who are on the Zoom for your active participation. The last but not the least, I want to thank the DNDi for giving me this opportunity to chair this session. It has made me very active. I've been following each and everything, and I've got more interest at the PRO, the prevention. I'm sure now with my colleagues from other countries, we in the Ministry of Health, and of course with partners, and now that we have we know the problem, we know what we can do. So they made NDV. I'm sure that once we follow this leishmaniasis prevention, epidemiology control, coordination, I'm sure we shall achieve the target set by the WHO about 2030. So I now hand over the mic to my colleague to take us through the poster presentation. I thank you very much for your cooperation, for listening. Thank you. Okay,
maybe
we should wait for 1 minute before Professor takes over from me. You take short time, just a poster presentation, and then I think we call it. Thank you.
I think as Professor Azrat is coming for the next session, I just wanted to, as a moment of relaxation and for us to breathe in and out, because the next session is actually going to be very exciting. It's supposed to be fireworks. We, the organizing committee, had want to make this poster session very exciting. And so the poster session, we have 5 poster presenters. They are also going to make an oral presentation, but they're going to pitch their poster. They can have their poster, and they have to pitch it. In 3 minutes, you just say what this is all about in 3 minutes. And then you get fire in 2 minutes. We ask you questions. Everybody, let us think of fiery questions, because we are training them also to be able to present in larger conferences. Some of them probably are young upcoming scientists. So this is the point. Some of them have been thrown in here so that they can have this quick fire. So I just wanted to motivate everybody, stay around, and let's have this quick fire from our poster presentation, and strictly 3 minutes, bang, you're off, and 2 minutes, bang, you have the questions, and we move on to the next one. We are going to grade the presenters, and at the end, we probably will come up who was the best presenter in the 2 days that we have today and tomorrow. That's all. Professor Azrat, the chair is yours. I just wanted to excite the team and encourage everybody to be listening and to ask questions to these young people.
Thank you very much.
Over to you. Thank you.
Yes, thank you very much. So this is the stage for the young investigators. Thank you for explaining the procedure. So yes, it's just 3 minutes. Of course, they are capable of displaying and of course teaching for 3 minutes, as Monique described. And we are serious about the time, as it will be clearer later why we do so. Okay, So what I will do, there are about 5 posters to be presented, possibly at least 4. And I will be introducing the speakers. Well, I wouldn't do all of it at once, but I will start with the first speaker, which is Melanie Etty. We see her on the video. Okay, Melanie Etty is a medical doctor from the United Kingdom, who is currently completing a Master's of Public Health degree in Global Health at Harvard Chan School of Public Health. Melanie worked as a clinical research fellow at St. George's, University of London, during which time she had spent a year in Kampala working on a project and which had an aim of measuring levels of protective immunity among group G streptococcus in mother and baby pairs. She also worked as a coordinator for the maternal, newborn and child health working group of the COVID-19 Clinical Research Coalition, which was actually hosted by DNDi. And her academic interests include the development and evaluation of strategies for infectious disease control in resource-limited settings. So with that introduction, I would now call upon Melanie Etty. She has projected the abstract, so you have 3 minutes to explain to us what this poster is about. Thank you very much.
Thank you so much for that wonderful introduction, and thank you for inviting me to speak today. So my name is Melanie, and I want to present a poster that is based on work that I conducted with the Migrant Health Research Group at St. George's University. And the poster is entitled Leishmaniasis Infection Among the Migrant Populations of Europe, a Systematic Review. So, as we know, leishmaniasis is a very common parasitic disease worldwide, and approximately 12 million cases are seen annually, and it accounts for about 50,000 deaths worldwide each year. And we know that migration and travel through endemic areas is a common risk factor for the acquisition of disease, and it has led to the reemergence of leishmaniasis in a number of non-endemic countries in Europe. But despite this, there's no coordinated disease surveillance in Europe. The disease is only notifiable in about 7 countries in Europe. So Spain, France, Italy, Portugal, Greece, Cyprus, Turkey. And actually in those countries, it's mainly visceral leishmaniasis that is notified, and cutaneous leishmaniasis is very scantily reported. And as a result, the data that we have for leishmaniasis spread in Europe is very poor and very limited. But despite that, we wanted to synthesize the data that we had to try and describe the burden of the disease, understand its epidemiology, and look at clinical outcomes among migrants as well. So we conducted a systematic review in line with PRISMA guidelines, and we looked at data published between 2000 and 2020. And after this screening process, we included about 77 articles, but the articles included work of medium to low quality, mainly a mixture of case reports, case series, and cohort studies. So I'll just quickly summarize some of the most important results. So we captured data from 7,546 migrants. And of those migrants, we were able to ascertain some demographic data for about 95% of these individuals. So the majority were male, 58% were male, 37% were female, and we weren't able to ascertain the sex for about 5% of people included. The vast majority of cases reported were of cutaneous leishmaniasis. There's a smaller number of visceral leishmaniasis cases, about 5%, and then less than 1% were mucocutaneous leishmaniasis. The majority of studies were based in Turkey, and you can see on the right there's a heat map just showing where the majority of cases studies were based. So primarily in Turkey, Italy, and Spain, with a smaller number in France, Germany, and the UK. And really one of the most striking findings was the diagnostic delay. So diagnosis of the disease ranged from about 2 weeks after presentation to up to 32 months. I think that really highlights that in a lot of circumstances, leishmaniasis isn't really being brought to mind as a potential diagnosis by clinicians who are seeing these migrants. And diagnosis of bacterial skin infection for cutaneous leishmaniasis was a common occurrence in the papers that we included. And interestingly, the most common country of origin among the migrants that were included in our review were Syria and Turkey. And with a lot of the conflict in Syria, we're seeing an increasing number of migrants migrating into Europe from there. So clinical outcomes were reported for about 415 migrants, so a very small number. And of these, the majority made a recovery, although many had scarring from cutaneous leishmaniasis, and some had some ongoing swallowing difficulty from the mucocutaneous leishmaniasis. And of the 13 that died, 12 had visceral leishmaniasis, and 5 of those 12 patients had HIV, which indicates the importance of screening for other causes of immunosuppression. So just to conclude, I mean, this review demonstrates that leishmaniasis is not uncommon in Europe, and it really highlights the importance of clinicians thinking about this diagnosis early in the diagnostic process. And it also highlights the need for a coordinated disease surveillance system in Europe to try and track the movement of the disease throughout the continent. So thank you very much.
Okay, thanks, Melanie. We have another 2 minutes for you. If there are questions for you, I'm sure there will be many questions, but we'll restrict them within 2 minutes. Questions, who's managing this? The Q&A, do you have any questions in the Q&A? No questions from the floor here. Melanie, when you say travel, is it within Europe or is it also outside Europe?
So we found that it was both, actually. So there are pockets of endemic leishmaniasis in Europe, so within the Mediterranean basin, so in Spain and in some parts of Italy, as well as in Turkey. But actually, so I think I didn't say this, but actually on the poster, I think 25 of the 77 papers described migrants moving within Europe. But actually there were also, so within the other 52 papers, it included a migration from Africa, also from South America, where there were cases of New World leishmaniasis, so Braziliensis, Guyanensis. But actually, I think because of the movement of migrants primarily from Asia and Africa into Europe, I would say the majority of cases were of old world leishmaniasis that were included in the review anyway.
Okay, thank you very much. Any other question?
There's a question here from Professor Paul.
Okay. Professor Paul K., would you like to speak? Otherwise, I would read the question. Melanie, how do your cases rates compare to those found in refugee camps where many of these migrants originate?
Yes, so the majority of cases that we found, or papers that we found, were actually based in refugee camps. And actually, I think it was mentioned earlier about the importance of screening and seeking out cases in these sorts of environments, and I agree. So I don't have a comparator. Some of the studies were case series based in hospitals, but some were clinicians who had gone, or researchers who had gone to refugee camps and were screening refugees there for the disease. So I know that money isn't endless, but certainly I think it would be a cost-effective measure to have outreach services that go to refugee camps and screen for the disease and perhaps catch it at an earlier stage so that they have better outcomes, less scarring, are less unwell when they present to hospital. So I definitely think that's important.
Okay, thank you. May I ask a question? Melanie, did you capture any data from Israel?
So I think there were 2 papers from Israel.
I'm just alluding to the Ethiopian Jews who migrated or were transferred from Ethiopia to.
Yes, so there were 2 papers. I think in my heat map, Israel was included there. There were 2 papers. But yes, I'm sorry, I can't remember the specific details, but I know there was some.
Okay, fine. Okay, unless there is one more question, then we will close this one at this stage. I don't see any questions from the floor, but also from the screen. Okay, Melanie, thank you very much.
Thank you very much.
Thank you very much. We will move on to the next speaker. Yes, the next speaker will be Paul Kibati, who is a resident of Kenya, field epidemiology and lab training program in the Ministry of Health. This is a program which is offered by Moi University in collaboration with CDC. Paul is currently attached to the division of vector-borne and neglected tropical diseases, where he supports the monitoring and evaluation activities to improve data management and use of the program. He is a graduate of the University of Nairobi. He had a Bachelor of Medicine and Bachelor of Surgery. And he previously worked as a medical officer, a medical superintendent, and a sub-county medical officer of health in Cutaneous County. Dr. Paul, you are welcome to present your poster. Dr. Paul. That's no problem.
No, it's coming up now. It's coming seconds.
Okay.
Good afternoon, good morning, everyone. My name is Dr. Paul Kibati. So I'm presenting a poster on the epidemiology of visceral leishmaniasis in Kenya. This was a retrospective review of data entered into the DHIS2 platform for the ministry. So as we all know, leishmaniasis is also known as post-kala-azar, is caused by the protozoan parasite of the Leishmania donovani complex. Globally, mortality rates as high as 95% within 2 years if left untreated. And in Kenya, we have 11 endemic counties, majorly found within the arid and semi-arid regions. And case management is important in order to improve the treatment outcomes. So the country aims to achieve a 60% reduction in morbidity and mortality. That is according to the Kenya Strategic Plan for Control of Leishmaniasis. And the treatment options are determined by age, primary or relapse of Kala-azar, as well as co-infection with other diseases. So in this poster, I aim to describe the treatment and outcomes of identified cases in the country between June and December of last year. So in the methods, as I've alluded to, we're able to respectively review data in the Division of Vector-Borne and Neglected Tropical Disease DHIS2 platform for that period. Some of the variables analyzed include number of clients diagnosed and treated by sex and age category, county of residence, month of diagnosis, patients cured, and number of defaulters. So from the key results is that a total of 686 cases. I think the poster being presented is not exactly the same, but 86 cases were reported in 8 counties, with males accounting for 68% of cases. The age group 5 to 14 years accounted for 41% of cases, with under 5s accounting for 20% of all the cases. The highest burden was found in Turkana, as well as West Pokot, which is not projected in this poster, with the lowest burden being found in Isiolo. 80% of the cases who were initiated on treatment during this period ended up being cured. During this period, there were also 3 deaths reported, giving a case fatality rate of 0.4%. With the month of October, given 24% of cases, which is 164 cases, and July recording the least number at 60 cases, which is 9%. So as for the geographic, in the heat map shown there, you can see that Turkana gave the highest number of cases. Also, West Pokot had over 200 cases during the same time period, with Kitui, Garissa, and Wajir also contributing cases. Marsabit, Isiolo, and Baringo having the least number of cases. If you look at data aggregated by sex, you'll be able to tell that more males were affected during the monthly. As per age category, you'll be able to tell that the age group between 5 and 14 years had the highest number of cases, except for the months of September, October, and November. As regards to treatment regimens, the antimonials and paramomycin, which is the first line treatment in the country, had 82% of cases were treated using this treatment regimen, followed by amisome alone and antimonials at 9 and 8% respectively. With regards to treatment outcomes, those who completed treatment were at 80%, with those who defaulted or stopped treatment at 0.1% respectively. So in conclusion is that the visceral leishmaniasis cases were reported throughout this period, with the disease mostly affecting males. The age group 5 to 14 years was the most affected by the disease, with West Pokot and Turkana counties having the highest burden of disease. Majority of the patients were treated using the first line in the country, which is antimonials and paramomycin, and the majority of the identified cases were initiated on treatment and cured of the disease as well. My recommendations would be that we need to enhance active case search in the high burden counties, which has been alluded to in our earlier presentation by Dr. Karutu. We need to institute awareness and sensitization programs targeting schools, as we can see that a good proportion of these cases are school-going children, so that awareness of the disease is found in the schools together with the teachers, and also to ensure complete data entry on the VL cases in treatment centers during follow-up, to ensure that all the cases are recorded as either being cured or in cases of dropouts. I'd like to acknowledge the Division of Vector-borne and Neglected Tropical Diseases, the National Public Health Institute, as well as the Field Epidemiology and Lab Training Program in Kenya. Thank you.
Thank you very much, Paul, for this informative presentation. It is open for discussion now. Questions from the floor? Yes. We have Dr. Munir asking a question.
Yeah, thank you, Dr. Paul. Mine is just a very simple question. In your slide, you mentioned in October 2020, you have to drop 25%, and in July, it is 7%. What is the transmission season in Kenya?
Maybe you can answer. You can answer that, Dr. Paul. Did you listen to the question?
Yes, I had the question. Thank you. So the dry season, after the short rains, after the long rains, which run from March to May, we have a long dry season which runs with the cold season and then a long dry season. And so the highest transmission is found during the dry season, which is towards the end of September and October. And so that is when we see that high peaks of transmission occurred in the country, just before the short rains again.
Okay, would that be variable between localities?
Pardon?
The distribution, the seasonal distribution of the disease, is that variable between the various localities? Kenya is a big country. How the disease is widespread. So the pattern, the seasonal pattern, does it really change from geographic location to, between geographic locations? Or is it the same pattern throughout all the 4 sites?
It's not the same pattern throughout the whole country. That tends to be the pattern in the arid and semi-arid areas of the country where most cases are reported. However, I did not do all the seasonal transmission for all the areas because I did not compare all the seasons in previous years. However, we do see that a peak of transmission is found towards the dry season, the long dry season, just before the onset of the short rains, which begin in October or November in the country. So it's not uniform for the entire country.
Okay. Any questions? Any more questions? Yeah. Also, maybe in the meantime, perhaps the last question, maybe from my side, it's about the small kids, the under 5s. Why do you think you have these under 5s? It's quite substantial. 20% of the patients are under 5s. What is happening? Is it peculiar to a particular geographic location, or is there any unique explanation for this? It's quite high, but we know this is happening in the eastern parts of the region, that is Somalia and perhaps southeastern Ethiopia. Can you explain why you have quite high proportion of under 5s also?
The risk factors for the under 5s have not been well brought out in our research so far. For example, currently I'm in the field responding to an outbreak in a new fossa in the country, which was previously not known to have disease, but had periodic outbreaks. So during, like, for example, this outbreak, we're trying to see if, the risk factors for children. We do know that because of some parents going to herd cattle, etc., with their small children, or hanging around the homestead with the cattle sheds next to the homesteads, that could be a possible risk factors, but we do not have adequate data to be able to say that the risk factor for under 5s is well brought out.
Yeah, thank you for that hypothesis. Yes, so we are finished with you, Dr. Paul. So thank you very much.
Thank you very much for having me.
Yes, thank you very much. We move on to the next presentation, which is, I'm not sure, Dr. Ramendra Pati. Okay, Dr. Ramendra is an assistant professor in the Department of Biotechnology, Microbiology, and Biomedical Engineering at SRM University in Delhi. And he was a postdoctoral fellow at FABSET, which was really a very prestigious fellowship in Latin America. And so he was affiliated with the Department of Medicine in Sao Paulo, the School of Medicine in Brazil. He was working with new therapies for Chagas disease and mainly aiming at the repurposing of drugs acting on cell invasion and autophagy, progression of all cells, potentiation of drug effect using the biopolymeric nanoparticulate drug delivery against T-Cruzi, the positive agent of Chagas disease. He was a research associate at the Translational Health Science and Technology Institute, which is in India, and he was working with, they identified FOXO1, as an essential for IL-9 induction in T helper cells. And of course, this has been published in Nature Communications Journal. And he has patented some of his findings and a compound which he has patented. So, Dr. Ramendra, I welcome you to this session. Please present your, for 3 minutes.
Yeah, thank you very much for a nice introduction and giving me opportunity to present my work, which I have worked on Mycobacterium tuberculosis. So you can see my title is basically the translational perspective of secretory protein of Mycobacterium tuberculosis encapsulated in biopolymeric nanoparticles. So there were 2 approaches that we have applied to see in our work. One was the immune response of Mycobacterium tuberculosis. And of course, we have taken the nanoparticles, biopolymeric. And why we have taken the biopolymeric nanoparticle, the reason was we have already seen all different type of immune response of secretory protein of Mycobacterium tuberculosis. But altogether, we wanted to see that whether if we take the nanoparticle which can encapsulate the secretory protein and probably can act like a adjuvant and can enhance the immune response. So we have seen two things as an outcome. One was the immune response and another was the oxidative stress. As you know that Mycobacterium tuberculosis, which is a vital intracellular pathogen, it resides inside the macrophage. Somehow, due to some of the cellular mechanism, our immune system don't recognize, and that's why Mycobacterium tuberculosis reside as a latent state for longer duration of a time. So what we have proposed in our study to take the chitosan as a nanoparticles, and then we have taken the secretory protein 10 and secretory protein 21 of Mycobacterium tuberculosis and encapsulated all those protein inside the chitosan nanoparticles. After having the screening of chitosan nanoparticles, whether this is nanoparticles or not, we have encapsulated this secretory protein and we have checked that whether if this chitosan nanoparticle, if it has the secretory protein, how the size and what is the charge on that one. So if you can see in my result one figure, it is showing that the chitosan nanoparticle that we have prepared it, the size was 390 nanometer. By definition, it is coming in the range of nanoparticles and having the polydispersity index of 0.2. At the same time, we have also confirmed the size using the transmission electron microscopy, and we have seen that the size was actually it was same like a dynamic light scattering. Also, we have checked the charge by zeta potential, and we have seen that the charge of the chitosan nanoparticle was 41 millivolt. This shows that by physical way that these nanoparticles were stable. Also, we have done the FTIR spectroscopy, which shows that whether we were able to make the chitosan nanoparticles or not. So, by seeing the data of FTIR, it had been confirmed that we have been modified the chitosan, make the nanoparticle. After that, we have also done the cytotoxicity assay because altogether we need to check the immune response or oxidative stress in the mice. So we have done the cytotoxicity assay and we have seen that when this chitosan nanoparticle was encapsulated into secretory protein, the cytotoxicity was almost compatible. And based on that data, we have also checked the biodistribution, like using the radio label technetium, and then we have seen that how this secretory protein is distributed in the different organ of the mice. So based on that, we have seen that this nanoparticle with the secretory protein that we have taken, it had a distribution in the different part of the organ in the mice. Then we try to compare some of the cytokine, and basically for us was quite encouraging to see that when this nanoparticles was encapsulated into secretory protein 10, if CFP10 means secretory protein 10, and CFP21 means that is the secretory protein culture filtrate protein 21, there was a pattern of the difference in the immune response, basically in terms of interferon gamma. And we have also checked some of the cytokine, but for us, interest was quite significant when we have seen the interferon gamma. And then finally, we have checked the colony forming unit. That was after the infection, mice were, like earlier, mice were immunized, the mice were infected with Mycobacterium tuberculosis. And the final conclusion was that when the mice having the immunization of CFP10 and CFP21 protein with the chitosan nanoparticle were having, of course, having the more immunogenic, and it was showing the more protection against the MTB. So this was altogether, the conclusion was that we having the Th1 immune response in terms of the cytokine, and altogether there was a better protection when we have taken the secretory protein of Mycobacterium tuberculosis. So this work was supported by department. Thank you.
Thank you very much.
Thank you.
Thank you.
Yeah, thank you, Dr. Ramendra. So we will invite questions. Let's see if we have questions now. Q&A. So anyone asking questions, Dr. Ramendra? Yes. Professor Olabo? Yes. Yeah.
Thank you, Dr. Hello. Good afternoon, everyone. Thank you, Dr. Ramendra, for a very nice presentation. As you're aware, the MTB has several secretory proteins. And why did you choose CFP10 and CFP21 for encapsulation?
Yeah, thank you. It's really a very good question. Basically, there are many secretory protein, but one of the thing, because this gene which is making this CFP10 and 21, it's come in the region of RD region of MTB. So this was one of the region that we have taken this protein. And second approach by that, in earlier of our group, we have taken the different secretory protein, even ESET6 was also in our lab, but somehow in my previous colleague has shown some encouraging result for CFP10 and 21. So that was one of the reasons that I have continued working on that protein.
Okay, thank you very much. Do we have questions in the Q&A? Dr. Ramendra, I just missed the last point, but did you say this is inducing a biased stage 1 response? Was that the message? Or?
Yes. So, okay. So you were asking about the cytokine induction, no?
Yeah.
Yes.
Was it biased for stage 1 responses?
Right, right. So basically, like Th1 immune response, as we have checked, like interferon gamma, IL-12, TNF alpha, some of the cytokine, because some of the cytokine which is predominantly for Th1 response, that's why this statement I have written in the conclusion.
Okay. Okay. Any more questions? If not, I would like to thank Dr. Ramendra for this presentation. Thank you very much. And we move on to the next one. Perhaps the last one. Yes.
Thank you very much to everyone. Thank you.
Sure. Okay. Now, the next presenter is Dr. Kishore Wasan, who is the Chief Medical and Scientific Officer at the Skymount Medical and a distinguished university scholar and adjunct professor in the Department of Urologic Sciences, Faculty of Medicine at the University of British Columbia. Dr. Wasan, he has published over 600 articles, 300 of them are abstracts, and over 300 peer-reviewed journals, articles in the field of cancer therapy and lipoprotein drug interactions, lipid-based drug delivery, and neglected global diseases. Dr. Wasan is a fellow of the Canadian Academy of Health Sciences, Canadian Society for Pharmaceutical Sciences, American Association of Pharmaceutical Science. He has won several prestigious national and international awards for his significant influence on drug delivery. He also co-founded the Neglected Global Diseases Initiative at the University of British Columbia. So I would like to invite Dr. Kishore Wasan for his presentation. 3 minutes.
Yeah, thank you. Thank you very much. Can you hear me okay? My video is not working this morning.
Very well.
Yeah, my apologies, sir. Well, thank you very much, everybody, for inviting me to speak about some really exciting work that our laboratory has been doing in collaboration with the Consortium for Parasitic Drug Development. That is a subshoot of the Bill and Melinda Gates Foundation, as well as ICO Therapeutics, which has now been moved into a new company called AMPI Technologies that is part of Satellus. And so what I want to share with you today is actually some exciting work that we've been doing with amphotericin B. Just to let you know, I've been working on amphotericin B for over 30 years. And I was, my professor, Dr. Gabriel Lopez Berenstein, was involved in the development of Abelset. amphotericin B lipid complex in the 90s. And so I'm very familiar with amphotericin B, and it's a drug that I've been working on for a very, very long time. So the purpose of our project was the following is, as you know, amphotericin B has been a mainstay in treating leishmaniasis and has been in the toolkit for physicians for a very long period of time. But as you know, amphotericin B is a polymacrolide antibiotic used in the treatment of bloodborne fungal infections and parasitic infections like leishmaniasis. However, it's got some limitations. It's parenteral in use, which makes it harder for accessibility to patients, particularly in rural areas of the developing world. On top of that, because of the parenteral use, you get parenteral toxicities. It's got dose-dependent nephrotoxicity. It's not very tropically stable, so we have to have a cold train, which is a really big issue. And so the Gates Foundation came to us and said, could you develop a novel oral formulation of amphotericin B that would be cost-effective, that would be accessible, that would get around the non-parenteral administration of the drug, and that would be tropically stable where you would not need to have a cold train? And could you have enough systemic exposure that it would actually have pharmacologic effect without the toxicities associated with the drug? So that was a really high bar to meet. And the short answer is we have developed now a formulation. And what I show you in the poster is the following, is we show you, first of all, we developed a novel reverse micelle formulation, which uses monoglycerides and diglycerides. And we demonstrated that it was tropically stable, doing accelerated temperature studies and humidity studies to show that it remained tropically stable. And in fact, we've got significant data since what I show you in this poster that we're able to maintain the integrity of the formulation and the stability of the drug for out to 120 days at 43 degrees C. So, and we've now developed another formulation that has gone into phase 1 human clinical trials that has a stability out to 2 years. The other thing is amphotericin B is really a drug that can be oxidized quite easily in the stomach. And so could we prevent that oxidation? And so what we're showing you here is in simulated gastric and intestinal fluid that we can maintain the integrity of amphotericin B without it being oxidized by incorporating it into our novel drug delivery system. And then finally, we showed the changes in particle size and how much of the drug is retained and how much is not broken down. But I think the critical study that was really exciting for us was to do the work in mice. And so what we show you in this figure here is this is an animal model that was developed at Ohio State University by our colleague Carl Werbowitz. And what we do is we infect the animals with leishmaniasis donnevii, and then we treat it with various groups. Either we have a non-treated control, we have a placebo control of the formulation without the drug, we have miltefosine as our positive control, and then we have a dose response of our oral formulation. And what you can see is within 5 days of consecutive treatment, we've been able to substantially reduce the leishmaniasis in the liver by greater than 90%. And of course, twice a day dosing, and then even once a day dosing at 20 mg per kg, we were able to show greater than 80% reduction. So what does this data together mean? This data together means the following, that we have developed a cost-effective, accessible, non-parenteral formulation of oral amphotericin B that is tropically stable, that will cost pennies a day, that you do not have to worry about refrigeration, and we've got a substantial reduction in the viral load. So we could take the formulation to the people. They don't have to be in a hospital. They don't have to be given an IV infusion of amphotericin B, and it could be used as a step-down therapy, as a complementary therapy with other drugs. I saw some of the other presentations from the WHO about other therapeutics, and it could maybe even be a primary therapy as a mainstay. The other aspect that I didn't have a chance to tell you about in this poster is that we have now completed human phase 1A, 1B clinical trials showing the safety of our formulation in human patients. And we've got some exciting new data showing that amphotericin B might have some antiviral activity against COVID-19 and some cell work that I presented actually a few weeks ago at the American Association of Pharmaceutical Sciences meeting. So taken together, we're hoping to be able to get to now a phase 2 clinical study in patients that have leishmaniasis. We are looking for a partner. We're looking to partner with anybody that's interested in helping us move this technology forward. And we're very excited about the work. We recognize the limitations of oral amphotericin B, but I think the key thing is it's about the systemic exposure, the tissue concentrations of getting AMP at a high enough tissue concentration to have pharmacologic effect. So I hope I got this done in 3 minutes, and I'm open to questions. And thank you very much for inviting me. It's a pleasure and honor. It's very early in the morning here in Canada, so I just got up to have breakfast. So thank you very much. And I look forward to the questions.
Thank you very much. Thank you indeed very much. Yeah, this is indeed exciting. And as you said, also it was understandable to be a high bar on you. So I think we have a couple of questions. Maybe there is one from the forum. Okay, and it's asking about side effects of this formulation. It's asking about any side effects that you have observed.
Yeah. So thank you very much for that question. Yeah, we're very lucky in that we've looked at renal function, liver function, GI disturbance, and so on. And in our human phase 1 clinical studies, we have not seen any side effects. Actually, I just published this paper in Antimicrobial Agents and Chemotherapy in September of 2020. So you can refer to that paper. But we don't have side effects. And that's really our adverse events of this formulation. And that's one of the advantages that we have over the parenteral formulation. As you know, that if you give an IV infusion to patients, you get people shaking and tremors and so on. You get red blood cell hemolysis that happens. Well, we don't have those issues with this oral formulation.
Okay, Dr. Watson, did you look at the pharmacokinetic, I mean, the tissue distribution in not only in the organs, but also perhaps in the skin?
Yeah, so we did, yes, we've done full pharmacokinetic studies and biodistribution studies in a number of animal models. Obviously could not present that today. And we found that the highest concentrations actually go into the organs where you have where you have a high amount of circulating macrophages or tissue macrophages. So it's kind of in a lot of ways behaves like the liposomal formulation, in that it goes into what we call the RES-rich tissues, the liver, the spleen, the kidney, and the lung. We did not find very much at all in the skin at all, because we have a novel mechanism by which we absorb this drug. We absorb this through lymphatic transport, which bypasses first-pass metabolism and is taken into the bloodstream through the lymphatics. And then from there, it's distributed to those major organs. The other exciting thing about this is that because AMP-B is packaged in the formulation, it doesn't actually get released from the formulation until it gets to the site of action. And that's what makes this a very exciting sort of delivery system.
Okay, thank you very much. Let me see if we have more questions. Yes, indeed, we have one question here from Professor Lobo.
Thank you for that very exciting presentation. I just want to ask about the cost and whether you've tried the formulation on fungi.
Yeah, actually, yes, thank you very much. Actually, the formulation was originally developed for systemic fungal infections in patients that were transplantation patients, cancer patients that secondary had fungal infections, as well as cancer patients and diabetic patients. And so we have actually tested this formulation in a number of fungal models, Candida albicans, Aspergillus. And in fact, one of our targets is to look at using oral amphotericin B in vaginal candidiasis in women as a secondary treatment to patients that are azole resistant. So yes, we've done many fungal infections, systemic fungal infections. In fact, that was actually the primary reason we did the work first, was actually in fungal infections. And then we were approached by folks about doing VL second. And so, yeah, we've done it in both types of disease states. And there was a cost question, yeah. So, you know, that's a very good question in that, we want to make this cost effective and safe for patients as well as, accessible. At the end of the day, as the head of the Neglected Global Diseases Initiative, we believe in the global access policy where developing drugs at or below cost for developing world indications is important to us. It turns out that the excipients that we're using are very cheap. We're talking, less than $1 a day. So we are very cognizant of the economics here. And so we believe that we have a very cost-effective and safe formulation where it's not very expensive for patients.
Okay. Yeah, I don't see anyone raising a hand. Okay, now I think we are almost done. So Dr. Wassan, I thank you very much for this exciting news.
Yeah, thank you very much. And if you want to learn, if you want to get in touch with me, please email me at kishore.wassan@ubc.ca. We are looking for partnerships, working with, I saw, as I said earlier, the WHO presentations with oral therapeutics, and we would be more than happy to work with you in helping patients and making a difference in people's lives. As I said, we've got human safety data, so we're excited that we are beyond the preclinical now, and I just didn't have time to share with you the clinical results, but we really want to go to the next phase. So thank you very much for having me, and I know it's been a long day for everyone there, so thank you for putting up with me as being the last speaker of the day. So thank you very much.
Yeah, thank you. We will indeed be interested in this progress, this work you're doing, and to have a better, more stable product of amphotericin B. So
yeah, thank you. So please contact me because we're looking for partnerships.
Yeah, thank you very much, everybody. So we ended this session. We all agree this was really a very good set of presentations, high-level science, and I thank all the presenters. And we will close the session right here. And please be reminded, tomorrow's session will begin. You are all invited, please. Everybody for participating, for the active participation in this second part of afternoon here in Nairobi. Thank you very much. Thank you. Anything else? Nothing else, right? Okay, just be here tomorrow, 12:30 East African time. Thanks.